Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and a very good afternoon to all the respected colleagues and guests. My name is Dr. Noman Khan and I'm working as Senior Registrar at Prime Teaching Hospital. And I have the honor of moderating this session, joint session by PSG, PSH and PSSLD. This session brings together leading experts to discuss key issues in hepatology and transplant. And I'm truly excited for what promises to be an insightful and encouraging session. Let's welcome our first speaker, Dr. Amanullah Basi, who will talk on important and challenging topic, that is deranged LFTs in pregnancy and how to proceed. Dr. Aman is working as Professor of Medicine and Gastroenterology at Dow University of Health Sciences. Please welcome Dr. Aman. Apologies. Before starting this session, I would like to call upon the chairs. First chair, let's welcome Professor Khalid Hamid, Professor Noor Wazir, Professor Abdul Qadir Khan, Dr. Haris Alwi, Dr. Amir Baksh, Dr. Abdul Malik Achakzai, Dr. Mehnaz Faisal, let's begin with the session.
हेलो आवाज़ नहीं आ रही है अब सही जी थैंक यू वेरी मच so this topic is a really very important topic and everybody knows that the pregnancies are occurring in every home and this is the normal physiological process and if this physiological process gets some abnormality that it will be an abnormal pathological process and we have to diagnose and treat promptly because this is the important two live things are present over here. One is mother, another is the fetus. So you have to secure and save the two lives in this situation. So starting with that the liver diseases and pregnancy, liver disease that are specific to the pregnancy are multi-systemic disease unique to the pregnancy, are pregnancy related physiological changes that may worsen the severity, are predisposed to hepatobiliary diseases. Diseases that are unassociated with the pregnancy but can occur during the pregnancy. Pregnancy also occur in the woman with the underlying chronic liver disease. Already patient is suffering from the chronic liver disease and having pregnancy. This is also another scenario. The liver during the normal pregnancy, usually you may see there may be a spider angiomas and palmar erythemas. And in the normal pregnancy, some albuminemia and alkaline phosphatase is usually raised and bilirubin levels may be decreased in the first trimester and gamma GT slightly decreased in the late pregnancy and serum aminotransferase level which may get affected in during the pregnancy, prothrombin time and serum concentration of the bile acids, especially in the fasting level. So the diseases which are very specific to the pregnancy, these are 5 diseases that are very common in pregnancy once there is an abnormality of the liver functions. So there is a hyperemesis gravidarum and intrahepatic cholestasis of pregnancy, acute fatty liver of pregnancy, HELP syndrome, preeclampsia. And the patterns of the hepatobiliary diseases in the pregnancy, there is a jaundice, pruritus, abdominal pain, nausea, vomiting, and liver biochemical test abnormalities. The American College of the Gastroenterology guideline, the liver disease in the pregnant patient, a gestational age of the pregnancy is the best guide. So hyperemesis gravidarum usually occurs in the first trimester, cholestasis of pregnancy in second and third trimester. HELP syndrome is in the second half of the pregnancy, and acute fatty liver of the pregnancy in third trimester, and preeclampsia is also in third trimester. So evaluation of the liver diseases in the pregnancy, the history is very important. Take the history. Is there any history of the pruritus? There is a history of oral contraceptive pills. Is there any history of the abdominal pain, polyuria, polydipsia? And note the trimester of the pregnancy, which is very important. And the physical examination, you will check for the temperature, blood pressure, and for the proteinuria, and you do the liver examination. Though it is difficult during the pregnancy, but you can if you try. And blood investigation, blood CP, which is very important, especially the platelet count, hemoglobin is very important. Liver function test is very important. Creatinine, electrolytes, glucose levels, uric acid, hepatitis A, B, C, or even A and E serology. And also the bile acids, the level of the bile acids, urine analysis, ultrasound, and also evaluation for the LFT, interpretation for the LFT. So for making it more easier, I make some scenarios and to understand perfectly the proper mechanism and how to diagnose and how to treat, because these are the very important condition, and there is a question of two lives. One is mom and other is the fetus. So 26-year-old woman, gravida 3, para 2, currently in her 10th week with a single-stun gestation, is hospitalized with intractable nausea, vomiting, and dehydration. During her 2 prior pregnancies, she also had severe nausea and vomiting, which resolved early in the second trimester. Her physical examination has a dry mucous membrane and gravid uterus. She has no any abdominal pain and does not have a palpable liver or spleen. So what is your first diagnosis? Anybody from gynecology? Yes. In the laboratory investigation, the SGPT is 175, AST is 122, and serum total bilirubin is 2.1. And amylase and lipase are normal. Albumin is slightly decreased from the normal value. Liver biochemical test, and prior to the pregnancy was not available. Right hypochondric ultrasound is normal, and urine analysis shows elevated ketones. Serology for ABC is negative, and anti-nuclear antibodies negative. Protein electrophoresis normal, TSH normal, and obstetrical ultrasound shows only single-stun gestation. So patient's clinical course and occurrence of the symptom early during the pregnancy are consistent with hyperemesis gravidarum. Criteria for the diagnosis. Common criteria for the diagnosis for hyperemesis are persistent vomiting accompanied by weight loss not exceeding more than 5%. Pre-pregnancy body weight is very important for diagnosis if you have. And ketonuria, which is unrelated to any cause. There is a ketonuria in hyperemesis gravidarum. And abnormal liver enzyme value occurs approximately in 50%. The most striking abnormality is an increase in the serum aminotransferases in the lower 100 or 2 to 3 times the upper limit of the normal, and rarely high as 1000 international units. 1000 units per liter. So hyperbilirubinemia can occur but rarely exceeds more than 4 milligram per deciliter. The serum amylase and lipase are increased as much as 5-fold as opposed to 5 to 10-fold increase in acute pancreatitis and are of salivary rather than pancreatic origin. So vomiting in the pregnancy usually occurs, in preeclampsia, HELP syndrome, acute fatty liver of pregnancy, and also causes of pregnancy related nausea and vomiting. But onset is in the later half of the pregnancy, usually in the third trimester. Hypertension is usually present and thrombocytopenia is common one. Now, in the case 2, 23-year-old woman, Gravida 2, Para 1, currently at 35 weeks with a single-stun gestation, is referred from dermatologist for intractable itching. The itching is primarily on the palms of the hand and soles of the feet. It is present day and night and keeps her from sleeping. The patient also had itching during her first trimester of pregnancy, in which the fetus died in the utero in the third trimester. So, what is your first diagnosis? So, this is the intrahepatic cholestasis of pregnancy. Intrahepatic cholestasis of pregnancy occurs in the second and third trimester. It is characterized by, pruritus and elevation in the bile acids concentration. For unknown reasons, the disease is seen more commonly in the cooler months. In the colder months, this is very common in the winter season. So the pathogenesis, the cause of the intracholestasis of pregnancy is unknown, but genetic, hormonal, environmental factors are likely involved. Estrogen and progesterone, it is recommended that the progesterone treatment may be avoided in the pregnant woman with a previous history of the ICP and immediately withdrawn when cholestasis occurs during pregnancy. Clinical manifestations, pruritus may precede laboratory abnormalities. Abnormal pain is uncommon. Encephalopathy or other stigma of the liver failure are unusual. The physical examination is not specific, may show excoriations due to scratching, and jaundice occurs in less than 10%. The serum bile acids concentration increase in ICP and may be the first or only the laboratory abnormality. The serum cholic acid increases more than quinodeoxycholic acid. The most women with an elevated bile acid ratio also have elevated total bile acid levels. As a result, obtaining a ratio does not enhance the diagnostic performance. The ratio of the glycine and tyrine conjugates is decreased. The elevation in the alkaline phosphatase, 5-nucleotidase, and total and direct bilirubin concentrations. The total bilirubin levels rarely exceeds 6 milligram per deciliter. GGT are normal or modestly elevated. Aminotransferases may reach the values greater than 1000 units per liter. The prothrombin time is usually normal, and prolonged prothrombin times reflect vitamin D deficiency due to cholestasis or to the use of the bile acid sequestrants rather than liver dysfunction. So ultrasound, the bile ducts are not dilated and hepatic parenchyma appears normal. The most women are diagnosed during the second or third trimester. The diagnosis of the ICP is based upon the presence of the pruritus associated with the elevated total serum bile acid levels or aminotransferases. So the treatment of ICP is some you use the UDCA and is considered as the first line of treatment in ICP, and the dose is 500 to 300 TDS, and hydroxyzocine 25 to 50 milligram per day, and cholestyramine 8 to 16 gram per day. So complication, hypoproteinemia induced by the vitamin K deficiency should be treated before delivery to prevent the hemorrhage. The hormonal contraception, contraceptive with the low dose of the estrogen can be initiated after normalization of the liver function test. Check liver function test after 3 or 6 months of such a contraception. So fetal follow-up and outcome is very important. In contrast to favorable prognosis for the mothers, ICP carries significant risks for the fetus. Fetal prematurity, meconium stained amniotic fluid, intrauterine demise, neonatal respiratory distress syndrome. So ideal time of the delivery is 37, but it should be between 35 and 37. Severe itching, jaundice, and prior fetal death. It is very important component for early delivery. So case 3, the 32-year-old woman, gravida 1, para 0, with single-ston gestation at 34 weeks of gestation is admitted to the hospital with a 3-day history of the nausea and vomiting, malaise and jaundice. Her blood pressure is badly elevated. Urine analysis shows trace protein and aminotransferases range between 200 to 500. Glucose is in the low normal range. White blood cell count and prothermometer time are elevated. So the most likely diagnosis is the acute fatty liver of the pregnancy, characterized by the microvesicular fatty infiltration of the hepatocytes. It is the disorder which is unique to the human pregnancy. Early diagnosis and prompt delivery have dramatically improved the prognosis and maternal mortality and should now be exception rather than rule. So it is rare with approximately incidence of 1 in 1,000 to 1 in 20,000 deliveries. It is more common with the multiple gestation and possibly in a woman who are underweight. Acute fatty liver occurs typically in the third trimester. The disease is always present before delivery, although it is not always diagnosed prior to the delivery. Now, case 4. A 23-year-old woman, gravida 1, para 0, currently with twin gestations at 32 weeks, is hospitalized with the hypertension for which methyl dopa had been prescribed earlier in her pregnancy. Despite the treatment, she continues to be mildly hypertensive and is developing a progressive rise in serum aminotransferases, which are over 85. The hepatitis serology and markers for the autoimmune hepatitis are negative. Her platelet count, peripheral blood, severe urine analysis, and right hypochondrial ultrasound are normal. So the differential diagnosis include preeclampsia, toxicity due to methyl dopa, and early acute fatty liver of the pregnancy. So the HELP syndrome is characterized by hemolysis with the microangiopathic blood smear, elevated liver enzymes, and low platelet count. 15 to 20% of affected patients do not have antecedent hypertension or proteinuria. So incidence, HELP syndrome develops approximately 1 to 2 in 1,000 pregnancy. Overall, it is 10 to 20% of the women with the severe preeclampsia and eclampsia. The majority of the cases are diagnosed between 28 and 30 weeks of the gestation. So this is the criteria and frequency of the symptoms on the basis of which you can decide, like a proteinuria, hypertension, right hypochondric pain or epigastric pain, nausea, vomiting, headache, visual changes, and jaundice. So symptoms typically develop in the third trimester. The most common clinical presentation is abdominal pain and tenderness in the mid-epigastric region, right hypochondric or below the sternum, nausea, vomiting, malaise, hypertension, which is more than 140/1/90, and there is a proteinuria. So serious maternal morbidity may be present at the initial presentation or develop shortly thereafter. DIC, abruptio placenta, acute renal failure, pulmonary edema, subcapsular liver hematoma, and retinal detachment. So diagnosis of HELP syndrome, microangiopathic hemolytic anemia. Signs suggestive of hemolysis include an elevated indirect bilirubin and low serum hepatoglobulin concentration. platelet count is less than 1 lakh, total bilirubin is more than 1.2, and serum AST more than 70 units. The cornerstone of therapy is the delivery. The pregnancy is more than 34 weeks of gestation, non-reassuring test for the fetal status, presence of the severe maternal diseases and multi-organ dysfunction, DIC, liver infarct or hemorrhage, renal failure or abruptio placenta, and significant maternal bleeding, less than 20,000 count, and pre-operative platelet count greater than 40 to 50,000. So the cesarean section is probably the preferable in the pregnancies less than 30 to 34 weeks of gestation if the cervix is unfavorable for the induction. So in addition to all these relevant conditions, there are also normal uh, diseases like hepatitis C, hepatitis B. So if these diseases are complicated, like they have developed the cirrhosis due to hepatitis C or due to hepatitis B, you have to treat these particular condition in addition to continuation of the pregnancy. But the decision of the pregnancy will be dependent on the severity and condition of a patient. Ideally, you should not advise the patient for the pregnancy if she has terminal liver failure or she has grade C chronic liver disease. So you have to be very careful. And if unfortunately a woman becomes pregnant, then what you have to do, you should treat the patient like you are treating the chronic liver disease. There is no any contraindication of diuretics. So thank you very much. God bless you. Uh, Prescribing this whole topic or suggesting these whole topics or defining these topics in short time, it is very impossible because the pregnancy is a very big chapter, and summarizing in a few sentences is not favorable for me. I tried a lot. Thank you very much.
Thank you, Dr. Abbasi, for the enlightening presentation. Our next speaker, Professor Altaf Alam, will be talking on hepatitis B current updates. He has worked as the head of Department of Gastroenterology and Hepatology at Sheikh Zayed Postgraduate Medical Institute, Lahore. Currently, he is serving as consultant gastroenterologist at Evercare Hospital, Lahore. Please welcome Dr. Professor Altaf Alam.
Thank you, Dr. Noman, for this kind introduction. Can we have the slides, please? Okay, the topic allocated to me is hepatitis B update. And I must thank the organizers, Professor Sher Rahman, Dr. Kamran Hassan, and Dr. Arshad Jidoon, for providing me this opportunity. I bring greetings from my hometown, Lahore, and I have no disclosures to make regarding this presentation. This is what I'm going to talk about. So, I'm going to talk about whom to screen, how to screen, whom to treat, how to treat, and when to stop treatment, and what's new on the horizon if I have time. The global burden of HBV continues to fall since I've been following it over the last 3 decades. And now it is 254 million worldwide. In 2022, WHO estimated that 1.1 million deaths were directly attributable to hepatitis B. There is a disproportionately high prevalence in the Western Pacific, Asian, and African regions. The bad thing about hepatitis B is that in 2022, only 13% of the patients were diagnosed and only 3% were treated. What is happening in Pakistan? The current prevalence is estimated to be around 1.6%, and this translates into around 2 million cases currently in Pakistan. Uh, every year, unfortunately, 30,000 plus new patients are added to this pool, and 12,000 patients die. So, overall, we still have a positive influx of new patients into the pool of hepatitis B. Thus, this is just highlighting how poor are we in the diagnosis and treatment of hepatitis B, and just compare it with hepatitis C uh, even 2 years back. Now, whom to screen for hepatitis B? My suggestion would be all adults at least once during their lifetime, and even children, if they are more than 1 years of age, must be screened at least once. There should be mandatory screening and antenatal TB, thalassemia, and HIV clinics, dialysis, and pre-surgery. Remember, this is the requisite for healthcare commission, that you have to do this prior to surgery. Annual screening is recommended for high risk group like hemodialysis. Now, how to screen? Either WHO approved ICT for surface antigen, or ELISA with a triple panel test, surface antigen, anti-HBs, and anti-HBc. To save cost, you can just do surface antigen and a negative history of vaccination to manage such patients. But it is important to check for anti-HBs and anti-HBc. If either of these are positive, no vaccination is needed. And there are implications of single anti-HBc test in the future management of a patient. So if this patient in future gets rituximab, you have to be aware of the reactivation of hepatitis B. So better to use the triple panel, but to save cost, you can do other things. Now, these tests on your left are mandatory. And I emphasize that viral load testing is mandatory. I'm not going to repeat these tests. You all know that. Most of you are liver specialists, practicing liver specialists. And whatever the current guidelines tell you, or the recent guidelines tell you, the management of hepatitis is based solely on viral load. How would you follow up a patient without knowing the viral load? How would you know whether your patient is compliant of treatment or not if you don't check the viral load? And even the guidelines which tell you don't do viral load, just check qualitative, or even don't check that in certain situations. When they talk about stopping treatment and modifying treatment, they again talk about e antigen and viral loads, etc. So, they are contradictory. I think the best solution is you choose the best of the available guidelines and do what you think is best for your patient. It's okay. The tests on your right are mandatory depending on the clinical scenario. And again, emphasize why check e antigen and HBV DNA, because you want to know the compliance on treatment. You want to start and stop therapy, and you need these data, monitoring response to treatment, defining flare up after stopping treatment, defining partial or non-response, and when you want to add on or switch therapy. So you can't get rid of e antigen and DNA for the time being. So what next? Educate your patient. Talk about the natural history, lifestyle, protection from hepatitis A and E. Not A in Pakistan, but certainly E vaccine is now available. Vaccinate for flu, pneumonia, and COVID-19. You have to talk about the drugs, diet, especially hepatotoxic drugs, alcohol, and also to prevent transmission to the rest of the family. So, family vaccination is a good opportunity at this time to enforce. Now, whom to treat? This is a $1 million question. You know the EASL guidelines? I don't find anything bad in these guidelines apart from this number 3 indication of more than 20,000. ASLD guidelines, which are going to be updated very soon. Again, I don't find anything wrong with these except this number of more than 20,000. Recent HBV treatment guidelines, just published last year. Excellent guidelines if you are a community physician. If you are dealing with elimination of hepatitis B and C, excellent guidelines. It even tells you what to do if BDNA or E antigen is not available. So good guidelines, you can get the best out of it. But look at the indication number 1 and 3, 1, 2, 3. They are the same as EASL guidelines. So get the best out of these guidelines. Chinese guidelines, in certain situations, they tell you don't do DNA. But as I said, when they talk about stopping therapy, follow up, and everything, they again talk about viral load and E antigen. So, they have double standards. So, what is my humble suggestions? Okay, if you don't have access to E antigen and HBV DNA, qualitative or quantitative, whatever you call it, which is extremely uncommon in Pakistan, just follow WHO algorithm. You have now the option of treating hepatitis B without checking E antigen and DNA. So my humble suggestion is a combination of all these guidelines. These are basically just 5 indications. Number 5 is just a repetition. So if you have significant fibrosis or cirrhosis, do check DNA quantitative, do check LFTs, do check E antigen, but start treatment. And that will help you in follow-up, as I have mentioned. Again, if you have any of these conditions like co-infections, family history of liver cancer or cirrhosis, immune suppression, comorbidities, extrahepatic manifestations, age more than 30, do check DNA, but don't go by any levels. Whatever the level, whatever the ALT, you start treatment. And why check DNA? Because it's going to help you in the management later on. E antigen, because it is going to guide you how to stop treatment. So do it, please. Treat HBV DNA is more than 2000 and ALT more than upper limit of normal, no problem with this. What I do in borderline cases, when the HBV DNA is less than 2000 or close to it, and ALT is close to normal, I check surface antigen quantitative. If it is more than 1000, I always start treatment. But you can just follow up these patients. It is a reasonable option at current time. But be careful about age more than 30. If you have a patient of age more than 30 with borderline indications, I would suggest go for treatment. Immune tolerant, if more than 30, well, is, as I said, a repetition. Number 2 indication already says treat more than 30. But I have put it up here just to emphasize this point that immune tolerant patients more than 30 years of age should be treated. And of course, the final indication, if DNA is not available, you treat. If surface antigen is positive, ALT is persistently elevated, and there is no other cause of liver disease. I sometimes laugh at this indication. If you do not have access to DNA, will you have access to screening for metabolic and autoimmune liver diseases, which it says. So, this is, again, showing double standards. So, my suggestion is get the best out of the available guidelines. Are on the side of treatment to your patients in current date and time, because that is the way forward. And try and find an excuse to treat rather than not to treat. And if you just look at these guidelines, it combines all the good points of all the 4 guidelines that I have mentioned so far. Now, how to treat? Fairly simple. No time spent here. Entecavir, TDF, and TAF. But remember that all these drugs need dose adjustment in CKD. I still see patient on hemodialysis and full dose of uh, entecavir or TDF. So adjustment of dose in CKD, and these nomograms are given everywhere. I don't need to repeat that. Use TAF or entecavir if there is CKD or bone disease or age more than more than 65. But uh, there is very little to choose from any of these drugs. So you can all start either on entecavir, TDF, or TAF on any patients, because the evidence is coming up in favor of TAF for all categories of patients, including pregnancy. Now, when to stop? This is again a $10 million question. Optimal endpoints are not very clearly defined. E antigen seroconversion and loss is one, DNA suppression is second, and surface antigen loss is the only one which is very clear. That you lose surface antigen, the patient is non-cirrhotic, you stop therapy. For many endpoints, indefinite therapy may be required, and if in doubt, continue. Recommend for all patients with advanced fibrosis and cirrhosis upfront that you are going to need treatment lifelong. Thus, patient selection and education is important. What about the E antigen positive? The well-known endpoints are E antigen negativity, anti-HBe positivity, and a consolidation period. How long? This is again debatable. More than 12 months, according to EASL and ASLD. What does it mean? 36 months? 24 months? They are not sure. APASL, preferably 3 years. So more clarity there. So I tend to use this 3 years consolidation period in my E antigen positive patients who want to stop therapy and they are non-cirrhotic. In cirrhotic, lifelong, whatever, E antigen positive or negative. And this is very good data to suggest that it is not only the consolidation phase. If it is more than 18 months, the relapse is lower, but also the age of the patient. If your patient is more than 40 and also the consolidation period is less than 15 months, you can see the relapse is as good as 100%. So, these are important points to remember when you are trying to stop therapy. So in E antigen positive, advanced fibrosis, cirrhosis, treat indefinitely. If E antigen become negative, seroconverts to anti-HBe, age less than 40, can consider stopping treatment after more than 12 months of consolidation phase. If age more than 40, you have to individualize decision. You can continue, you can stop. Consolidation should be preferably close to 3 years, in my opinion. And remember that whenever you stop, whether it is E antigen positive or negative, need to monitor for flare up and for relapse, which requires retreatment. What about the E antigen negative? The simple answer is treat indefinitely. But now my patients are coming to me that they have read that E antigen negative non-cirrhotic treatment can be stopped. So at least we should know what the answer to this is. According to the guidelines, if all the numbers are good, surface antigen still positive, but E antigen negative, anti-HBe has appeared, biochemically the patient is normal, then you can stop therapy, provided the patient can come back for repeated and regular follow-up, which is very difficult. It is every month for 6 months. So it is not just and you have to check DNA, everything. So, rather expensive business. So you can make a decision, continue indefinitely. Cirrhosis, yes, always indefinite. But if you stop therapy, close follow-up has to be ensured. And whom do you stop therapy? In non-cirrhotic and in those who have had at least 3 years of therapy, and all the things are negative for at least 3 years. So that is the ideal way to go. The Apostle paper in 2021 says that you can make that decision based on surface antigen quantitative. Less than 100, stop. Any number greater than that, especially more than 3,000, you should not be thinking of stopping therapy. So, there are new parameters to help you in deciding when to stop. And Japanese guidelines have gone up one step forward in including hepatitis B related core antigen in the stopping decision. So, surface antigen, quantitative, as well as hepatitis B core related antigen, to make it more safe, to make it more productive. And these are just, initial data. You may or may not, core related antigen is not available in Pakistan, but certainly surface antigen quantitative is available for many, many years now. So you can use these for deciding whom to stop, whom not to stop. So what is the way forward? In E antigen negative, fibrosis, cirrhosis, don't stop. Lifelong. If you have given 3 years of therapy and the patient is DNA negative, ALT is normal, patient is non-cirrhotic, you can consider stopping therapy provided the patient can come back for close follow-up. If you do that, 20% will lose surface antigen and 60% will remain off therapy. So there are some benefits. You can't just say that you don't want to stop therapy, but it's a difficult business and you have to select your patients accordingly. Mother to child transmission, nothing new. WHO has already also mentioned that DNA more than 200,000 start treatment in the third trimester and give immunoprophylaxis to the baby. Now coming to some new data. This is what we are achieving, partial cure. The aim is functional cure and if possible, complete cure. I'm not going to go into the details. To achieve these two ends, which really means reduction or negativity of cccDNA and integrated HBV DNA. If you achieve that, it is complete cure. There are many, many drugs, many, many classes which are under trial. Just one drug has completed phase 3 trial, and this is gone into phase 3 trial. This is phase 2 data. Bepirovirsen, I call it Bepi to make it easy. It does help 28% on nucleoside analog and 29% off nucleoside analog on a single agent for 6 months, lost surface antigen. So something for the future. There are many, many strategies to achieve HBV cure. I'm not going to talk about this, but generally they mean a combination therapy with or without nucleoside analog. So the only thing that is available today is interferon, either switch or combination. And this data was presented at EASL 3 years back, where if you use a pegylated interferon add-on or switch after 2 to 3 years of therapy, you will be able to achieve surface antigen loss in about 30% or so patients. And if your patient at this stage has a surface antigen quantitative of less than 100, then you can see the loss, surface antigen loss approaching 60%. So there are approaches which will be helpful for the future and will help you in managing your patient. I thank you for your patient listening.
Thank you, Professor Altaf, for sharing such valuable insights. The next talk is by Dr. Bilal bin Mukhtar, who will speak on management of portal vein thrombosis. Dr. Bilal is working as the head of department at National Hospital Lahore and associate clinical professor at University of Cretan, Nebraska, USA. Before moving to Pakistan, he served as associate professor and assistant program director at University of Tennessee, Memphis for 8 years. Please, Dr. Bilal, take the stage.
Hello? Yeah, the laptop is getting connected, so I'll take a few minutes to, first of all, thank you, Dr. Sher Rahman, Dr. Kamran, for inviting me on this prestigious forum today in front of a global audience of highly esteemed colleagues and friends. So I really want to appreciate that. So my topic today is going to be management of portal vein thrombosis. So when I saw the topic, I thought it will be an easy topic. But when I went deeper into it and explored it, I realized there was much controversy and confusion about the various aspects of its management. All right, so I'll just tell you quickly that around 2010, I was a transplant hepatology fellow at University of Tennessee in Memphis, and I asked my program director at that time, Dr. Satish Nair, how do you manage when you develop portal vein thrombus in cirrhotics? So he gave me a single line answer. He said, if acute, treat. If chronic, don't. And however, we have come a long way since that time. So I'll be talking about a basic classification of portal vein thrombosis. We will be focusing primarily on portal vein thrombus in cirrhotics because that's the most common clinical scenario. And I will also discuss what I came up with, a 3+4 question and 4 brainstorm pause strategy whenever you encounter this entity. So let's get going with that. Now, I like to always start my talks with a case presentation. I think that garners more attention, and it's much easier to transfer our knowledge from bench to bedside. So let me just read through that real quick. We have a 50-year-old female who presented with progressive weakness, abdominal distension, and pain for the past 2 weeks. History of hepatitis C treated in the past. These are the basic labs, and you can just take a quick look. But Billy's 2 important ones, INR 1.5. Platelets 99, you have WBC count, which is elevated and a lactate of 3. An ultrasound was done, which showed cirrhosis, ascites, portal vein thrombosis with few collaterals and few loops of dilated small bowel. What is the next best step in management? So I'll just appreciate if there's a few raise of hands. So these are the options. Anybody thinks we should start anticoagulation right away? Hypercoag workup needs to be done. Should we do an EGD? Or maybe get a CT or just observe? So, all right, so we'll go on and we'll come back to this question at the end of our talk. And hopefully we'll have more insight on that. So portal vein thrombus, why study? Why study this entity? And for multiple reasons. But first of all, for the past 15 years, we have an evolving understanding of liver and the coagulation cascade abnormalities. In addition, portal vein thrombus remains, to date, a very challenging clinical conundrum. And finally, it does impact mortality and transplant outcomes. So for these reasons, I think we should all know about it. Now, some basic statistics. Global prevalence, about 1%. In cirrhotics, however, the 5-year incidence is pretty impressive. It's about 11%. In terms of etiology, you can see that this pie chart shows cirrhosis and underlying hepatocellular cancer constitutes about 50% of these cases. The rest of them are shared by metastatic liver disease, other infections, inflammatory processes, and myeloproliferative disorders. We can divide portal vein thrombus into recent and acute and chronic based on the duration. If it's less than 6 months, we call it recent. Do note that I'm not calling it acute, and I'll come to that as well. A little bit about pathophysiology and the risk factors. So the portal venous system is a unique environment, vascular environment, where there is slow flow, there's low pressure, but there's very high volume of blood passing through. So it's a very unique setup there. All of the venous thrombosis that happen occur due to multiple factors coming together as part of Verko's triad, which includes stasis, hypercoagulability, and endothelial injury. The risk factors can be broadly classified into 4 major categories. Either it is thrombophilia acquired or inherited, and then importantly, local factors. Could be surgery, it could be infection, it could be inflammation, even procedures like TIPS. And finally, we have systemic disorders, and you can read them. It's important to note that in cirrhotics, the main problem is stasis. There's the slow velocity of blood in the portal vein that is the primary culprit. However, in non-cirrhotics, the other way around. Most of the time, you'll find an underlying hypercoagulable state, or they have an endothelial injury. In cirrhotics, our old wisdom and conventional wisdom tells us that patients with cirrhosis or chronic liver disease have an underlying acquired bleeding disorder. However, that paradigm has shifted. We know that cirrhosis could be, actually it is, a risk factor for thrombosis. And why is that? If you look at this picture, you will see that there's a rebalanced hemostasis in patients with cirrhosis. So you do have low platelets, but on the other end, you have high von Willebrand factor. And you have low coagulation factors, but on the other end, you have high factor VIII. You also have deficiency of protein C and S. So that actually tilts the balance a little bit towards prothrombotic tendency in patients with cirrhosis. So the old myth that people with liver disease are auto-anticoagulated, it actually is not true. And that's very important to understand. And I put this schematic as well so we can remember this, that how delicate and precarious this balance of coagulation is in patients with liver disease. You can see the anticoagulants and procoagulants on each side of this balance, and it becomes more delicate as the child staging advances. You will see that the triangle in the middle was larger, but in patients with cirrhosis, it shrinks down. So much so that the external factors like DIC, shock, infections can tilt the balance either way very, very quickly. Now, a picture is worth 1,000 words. And I want you to imprint this one picture in your mind, which will help you answer the 3 fundamental questions when you encounter anybody with portal vein thrombus. So the foremost is it a recent thrombus or chronic? Second, you ask, is there underlying cirrhosis or is no cirrhosis? And finally, extremely important, is there an underlying malignancy? If you look in this picture, about the acute thrombus in non-cirrhotics, all I will say, patients typically present with pain and they need to be anticoagulated. And that's it. In terms of the cirrhotic patients who do have an acute thrombus, these people usually, the symptoms are mixed, don't usually present with a lot of severe symptoms. Anticoagulation, we will talk about that, which patients need it. And importantly, up to about 40% of these patients will spontaneously recanalize the portal vein. Patients who are cirrhotics and develop chronic portal vein thrombosis, it's important to note that they will have a significant collateral development in form of shunts, portocaval shunt, they have splenorenal shunts, and similarly others. Now, another important point about that, and I'm sorry, I think the font is small, you may not be able to read it, but there is impact of portal vein thrombus in a chronic setting if it involves the confluence or it stretches into the superior mesenteric vein. And extremely important is to diagnose tumor thrombus. And how will you do that is that if the thrombus is breaching the vessel wall and if it is arterially enhancing. It's important to note because up to 25% of the patients will have a bland thrombus in there as well. So shifting our focus to recent portal vein thrombus in cirrhotics. Now, I want to thank AASLD for coming up with this nomenclature in 2020. Before that, there was confusion all around. They, however, said that we should divide a portal vein thrombus in cirrhotics based on chronicity, the extent, the degree of occlusion, and not only that, but also in terms of its evolution into being a progressive or a regressive clot or stable one. If it is less than 50% occluding the lumen, we call it minimal portal vein thrombus. More than 50, we call it partial, and rest of it you can see that here. Now, how do we diagnose it? Some of these things are basics, but I'll go through that real quick. In cirrhotics, it's usually the presentation is insidious because they already have lots of collaterals. However, whenever you see new decompensation, for example, somebody come in with new ascites or worsening ascites all of a sudden or very still bleed, always think about development of a new portal vein clot. Non-cirrhotics, we know pain and fever. Severe symptoms, extremely important. Do not miss intestinal ischemia. You have to look out for these patients with distension. Bloody diarrhea maybe could be a clue. Leukocytosis, acidosis. Doppler ultrasound is usually how we start with. Sensitivity, specificity is pretty good. However, do not miss on getting a CT scan with IV contrast, because without that, you cannot characterize what type of clot are we dealing with. And then finally, it's important that you do not require a hypercoagulable workup if somebody with cirrhosis is coming up with portal vein thrombus. There are some exceptions to that, but I'll skip that in the interest of time. All right, so this is a quick picture I wanted to put up here. So you can see that how a chronic portal vein thrombus looks like. You will see that there is development of collaterals, and these collaterals could be present either within the portal vein thrombus or outside this portal collaterals or shunts. And on a CT scan, you will see bag of worms, as is visible here. All right, moving on to the management challenges, because that's the core of our talk today. What's the problem? Why portal vein thrombus poses a clinical challenge? Well, number one, there are limited studies. There are few guidelines, more like guidance statements from societies, but there are multiple and they're all over the place. The last guidelines from EASL, for example, were from 2015. Determining acute versus chronic is not that straightforward. Studies have shown that up to 15% of patients may already have collateral development at 2 or 3 weeks time. So don't be tricked by that. If you see few collaterals, you call it chronic right away. You have to look at the whole picture. And then obviously there's a perceived risk of anticoagulation, and therefore it's the challenge. But the two key questions that you have whenever you encounter PVT are, one, what is the bleeding risk if I put this patient, this cirrhotic patient, maybe child C, on anticoagulation? What's the risk of bleeding? And second, is there a real benefit, if at all? Because as we talked about, 40% of patients will recanalize. So let's talk about the bleeding risk first. Most people, when they look at a cirrhotic and they look at the low platelets and elevated INR, they freak out. They don't want to treat that. They don't want to put that patient on anticoagulation. However, what they don't remember is that it's an altered hemostasis, and the balance is more towards prothrombotic state because they have von Willebrand factor that's elevated and there's protein CNS deficiency, as we saw on previous slide. So at the baseline, when you're about to start treatment, there is no increased risk of anticoagulation. And there are other studies, which I'll allude to, come to in a few more slides, which show that even when they are on anticoagulation, there's no increased risk of bleeding. So the key question, is there real benefit of treatment? Should we even do anything about it? Well, obviously, it's no-brainer that when you improve the portal flow, you're going to decrease portal hypertension, you're going to decrease risk of decompensation, and the phenomenon of parenchymal extinction is something I found very intriguing, that this thrombus can create microthrombi and emboli distally, creating damage to the hepatocytes and resulting in further decompensation and extinction of the cells. And of course, people who are on liver transplant list or are potential candidates, recanalization will preserve a possibility of anatomic anastomosis, makes it technically much less challenging. And naturally, long-term complications can be avoided, like variceal bleeding and portal cholangiopathy. But the big question, is there real survival benefit? We are talking all about this, a lot of this is theory, but are we going to improve patient survival? So this study by Barry et al. In 2015 is oft quoted. So they noted that people who had portal vein thrombosis and they were not treated, they actually, when they were adjusted for the confounders, the risk of death or for adverse outcome in terms of liver transplantation was really below 1. So that didn't make a difference. So big study, quoted several times, a lot of subsequent studies in transplant candidates followed. All right, so however, contrary to what we just saw, a recent meta-analysis, which included 5 studies, 500 patients, showed that actually with treatment, there was higher likelihood of achieving partial or complete portal vein recanalization. So what we know is the treatment works. And what they also saw, most important part of this study was lower risk of all-cause mortality. So you can see those numbers there. And in addition, as we had just previously talked about, what about the bleeding risk? They noted there was no significant difference in the rates of bleeding overall or specifically from portal hypertensive complications. So this is a schematic and the picture showing you the results we talked about. You can see people who were anticoagulated had lower mortality, all-cause mortality, independently of thrombosis, severity, and recanalization. You can see this forest plot showing that. All right, coming down to the management approach. And over here, I must say that there are 4 primary questions that you have to answer. So we talked about the 3 questions initially. Now we're talking about the 4 questions when we have to further decide about the treatment. What are we going to do? So the first, are there symptoms? Second, is the clot recent or is it chronic? What is the severity? Minimal, we talked about that, partial or completely occlusive. And is this patient a transplant candidate? It's the most critical question. And what are we going to do? After we've answered these 4 questions, we go on to the, I like this algorithm because it just came out fresh out of press. Actually, AGA published this just a few months ago. And so what they talk about is you need to get a CT scan. And once you see that clot on the CT, the first step, rule out intestinal ischemia. Do not forget that because sometimes it's easy to miss in a murky picture of cirrhotic patient coming in with other issues and then this new clot. So do not miss it because that can save a life. Number 2, you perform an EGD. That's a little bit counterintuitive. You would wonder, why do you have to do an EGD? Well, important because you want to see what is the variceal status. Because if the varices are there, then you have to manage them. And how do you manage? When you see varices with high-risk stigmata, you put them on non-selective beta blockers unless they're intolerant. Don't put bans on them. Personal experience, sometimes we put bans, but they started bleeding once anticoagulation started, and it was a bit of a nightmare. So, however, if no beta blockers, then you have to ban them. Now, let's go on to the next step. Okay, so this is a little bit busy, but I'll walk you through it. So look at this part. Now, after those 2 first steps, we look at if the thrombus is 50% to 100% occlusive, and it's recent. Those 2 things. Remember the 4 questions. What do? You consider timely treatment. However, also, if it's complete and chronic, naturally, we said no anticoagulation because the clot is not going to recanalize. If it is less than 50% occlusive, you still consider treatment. On what conditions? Well, 2 conditions, as we spoke earlier. If they're symptomatic or they are transplant candidate. But don't forget, this is an important one. This is according to the new guideline. At 3 months, you don't just let go of the patient. You just say we're going to treat or not treat. At 3 months, you have to reevaluate with another CT scan. And this CT scan, if it shows clot progression, you consider treatment. But after you consider treatment, there's another step. And I added that it was not there, but then rule out contraindications for anticoagulation. Not every patient is going to be a candidate for anticoagulation just because, excuse me, either they have very poor prognosis or they are high fall risk patient, for example, hepatic encephalopathy, or they are poor compliance, or it's a personal preference. So always look at that. And the best outcomes are going to be in people who are awaiting liver transplant or they show progression of the liver disease, and of course, prothrombotic state if that is diagnosed. All right, so I came up with this 3+4 question and 4 pause strategy. So to make the management decisions simple. So what do? Well, first of all, you pause when you notice portal vein thrombus is diagnosed. And what do? You ask 3 questions. The purpose of these 3 questions, as we had talked about, is to find out what type of portal vein thrombus are you dealing with. Now, in the next step, you document, let's say that it is a recent portal vein thrombus in a cirrhotic, because that's going to be the most of the time you will see that most common clinical picture. That's where you pause again. And what do? That you ask these 4 questions that we talked about. And what is the purpose of these questions? To see which candidate will be a treatment candidate. And that's where this algorithm by AGA will come into play. Now you're considering anticoagulation. Before that, you pause again and you rule out those contraindications we talked about. Now, do we stop at that? No, there's one more pause, remember, and that is at 3 months of treatment. You have to reevaluate. And how do we reevaluate? I will come to that. Well, actually, there's a slide after this, but what are the treatment options? If you end up deciding that these people do need treatment, so the 3 categories of medications we have, the age-old warfarin. Yes, most data is available on that, but we all know how cumbersome and unreliable the testing can be in patients with cirrhosis. Low molecular weight heparin. Well, inconvenient for sure, but very helpful in patients, especially if they're going to get any procedures done. And for child C, that may be the only therapy. Why? Because the DOACs, most studies these days, and there's growing body of evidence, very easy, convenient to take. However, don't use in child C patients. So you have to remember that. Preferred agents are apixaban. We like it better than any other agent. And avoid Xarelto or Rivaroxaban because of its associated hepatotoxicity. All right, how long do you treat these patients for? So you have reached this point at 3 months. You're going to treat, going to watch the treatment response. A partial regression, you continue. Complete, you either stop or continue the treatment candidate. No response or progression on therapy, stop or consider other therapies. And sorry, I'm going to get a minute or two because of the pointer issues, but indefinite for these conditions. If there's bowel ischemia or extension, you don't stop the therapy. TIPS can be used if they have additional indications or if it's going to impact the technical feasibility. Our question, real quick, I have highlighted the tip-offs in red, pain, all these factors you probably know by now. We're talking about intestinal ischemia. What's the next step? CT's abdomen. This is what it shows, a clot in portal vein, a clot in SMV. You got ascites and other things, and what are you going to do next? EGD first, and then you start the anticoagulation. So take-home points, portal vein thrombus, very common in patients with cirrhosis, associated with progression of portal hypertension and mortality. It remains a clinical challenge, and a decision to pursue the treatment is going to be individualized, but do not miss the life-threatening bowel ischemia, do not miss the poor prognostic tumor thrombus, and do not miss the prothrombotic state that you can easily treat. CT, EGD if they're cirrhotic, and then of course you're going to treat these conditions, symptomatic, recent, and transplant candidates. Thank you very much.
Thank you, Dr. Bilal, for an excellent presentation regarding portal vein thrombosis management. Next, I invite Professor Zegam Abbas to speak on emerging therapies in MASL and NAFL. Professor Zegam is working as consultant gastroenterologist at Ziauddin Hospital and at the Aga Khan University Hospital. Please welcome Dr. Zegam Abbas.
Bismillahirrahmanirrahim. I am thankful to the organizers for inviting me to deliver this talk. So we all know that weight loss works, and this parameter has been shown again and again on presentations on NAFLD. And what does it show? It shows that if you are able to lose your weight 3%, then you are able to revert back steatosis in many of your patients. 5% weight loss results in improvement in ballooning and inflammation. 7% weight loss results in MASH resolution, and 10% weight loss results in reversal of fibrosis in about 45% of your cases. But this weight loss is difficult to achieve, and only less than 10% of your patients would be able to get this weight loss on lifestyle modification in 1 year of time. So there are current approaches available to improve the non-alcoholic or non-steatotic fatty liver disease, and the key role of weight loss cannot be overemphasized, and weight loss can be achieved with dietary modifications, physical activity, and treatment of your diabetes and cardiometabolic risk factors with the relevant medications. And in relevant medications, we know that now we have GLP-1 receptor agonist, and we have SGLT2 receptor antagonists available with us. Now targeted therapies are also available, and these targeted therapies used to be vitamin E and pioglitazone, and we'll discuss briefly these also. And we should not forget that GLP-1 and SGLT2 receptor antagonists, they are also the targeted therapies for MASH, and we'll discuss briefly their role in MASH even without diabetes. And then we have resmetirom. If the patient develops cirrhosis, then these patients may be offered something like glucophage, and it has been shown that the glucophage reduces the risk of hepatocellular cancer in these patients, and statins reduce the portal hypertension, intrahepatic portal hypertension. We have been using many drugs in the past before the recent drugs were available, and these drugs included vitamin E, pioglitazone, metformin, statins, omega-3 fatty acids, obeticholic acid, and then we have the GLP-1 agonists available with us, and then SGLT2 inhibitors with us, and we have been using these drugs off-label for our fatty liver patients even without diabetes. And this study is repeated again and again because this is very important pivotal study. And this study looked into the pioglitazone and vitamin E role in patients who had non-alcoholic steatohepatitis. And you can see this study, they were able to achieve improvement in steatosis as compared to placebo and improvement in lobular inflammation in many of these patients who are treated with these. And this is the vitamin E role in non-alcoholic fatty liver disease. And this meta-analysis shows that vitamin E does help some of these patients. And promising results are seen in patients who are obese, 15 to 50 years of age, who had their elevated AST levels, and who are able to take 400 to 800 international units, and who are also able to undergo lifestyle modification. So survival benefit has been shown even with vitamin E in spite of lot of concerns, and this shows that vitamin E improves the transplant-free survival and prevents the decompensation in patients who have the MASH or NASH. What about pioglitazone? And pioglitazone, even without diabetes, we have been using pioglitazone in the past, and this has been shown to improve the fibrosis in our patient, and this is one of the meta-analysis which shows. So the role of pioglitazone and vitamin E, we cannot dismiss that these are the outdated drugs. There are always safety concerns, but these safety concerns have been mitigated with the recent data. There was one safety concern that vitamin E possibly associated with all-cause mortality risk. If you are using 800 or more vitamin E, there is a risk of hemorrhagic stroke, or there is a risk of prostatic cancer. Again, with pioglitazone, there is a weight gain, risk of osteoporosis, and bladder cancer. So when we are using these drugs, we have to be careful, and we have to discuss with our patient the risk-benefit ratio with these drugs. And why not to combine these drugs when we need these drugs in combination with recently available drugs. We have been using a drug off-label for our MASH patient before the resmetirom was available, and these drugs included GLP-1 receptor agonist and SGLT2 receptor antagonist. And this off-label use of these drugs that improve the insulin sensitivity, and these drugs have shown us that these drugs do work. So recently, FDA laid on efficacy endpoint for phase 3 trials, and these efficacy endpoint included MASH resolution, which means the resolution of steatohepatitis without any worsening of fibrosis. And the second point may be that a fibrosis improvement, more than one stage in the fibrosis improvement without worsening of steatohepatitis, or both of these. So these are the recent guidelines that after the resmetirom became available, and resmetirom was included in that. But we should not forget the cardiometabolic risk factors that these patients have, that may be precipitating MASH or that may be aggravating MASH, and we have to look after diabetes with appropriate drugs. Not every these patients should be treated with sulfonylurea, but we have to choose appropriate drugs like GLP-1 agonists or SGLT2 inhibitors, and we have to control dyslipidemia with statins also and look after obesity. So what is the role of SGLT2 inhibitors in NAFLD on liver fat and ALT level? As you can see, and there is improvement in the liver fat and ALT when we are using some of the drugs like empagliflozin in this slide. And the systematic review shows that when you are using this drug, there is improvement in the liver fat, there is improvement in the liver enzymes, but there is no evidence of improvement in liver fibrosis. And this is the one of the studies. This study was done in non-diabetic patients, patients without diabetes. Empagliflozin was used in these patients, 10 milligram. And if you look at the results that even patients who do not have diabetes, when you are using these drugs like SGLT2 inhibitors, empagliflozin, there is improvement in the MRI protein density fat fraction in these patients. So coming to the GLP-1 agonist, we have been using these drugs for weight loss, and there is improvement in the weight loss, we are able to achieve weight loss of about 6 kilogram in 30 to 40 weeks of therapy in these patients by using semaglutide, in this case about 1 milligram per week. And this is one of the study that shows that even if you do not have diabetes mellitus, and when you are using semaglutide, your patients of MASH, there is improvement as far as the weight loss is concerned, and this weight loss does happen in patients without diabetes. And we know when there is a weight loss, there is improvement in MASH. So this is a study done in MASH patients, and this study shows that the semaglutide is a better option as compared to the placebo in resolution of NASH without worsening of liver fibrosis. But if you look the second panel, which is dealing with fibrosis, there is not much improvement in fibrosis. So GLP-1 drugs are helpful in improving MASH, but alone there is not much improvement in fibrosis, so they have their role in perhaps in combination, as we'll discuss later. Now we have the oral formulations available of semaglutide. Oral formulations are good in diabetes, but for weight loss they are not so good. So you have to be careful with oral semaglutide. So we do not know whether how much fat improvement or MASH improvement occur while we are using oral formulation. And this is only day before yesterday that we heard this news on media, and this is about new drug by Eli Lilly or for glipron, very new drug, difficult to pronounce now because came only day before yesterday. And this shows that this drug is oral drug, you have to take daily, but these drugs appear to be better than semaglutide that we have been using subcutaneous weekly. So they have compared the results with Ozempic and Mounjaro, and they have shown the results are at par with subcutaneous administration of these drugs as far as the weight loss is concerned. So when there is weight loss, there is improvement in MASH. So caution to the pharmaceuticals who are now flooding with daily we are hearing one or two pharmaceuticals bringing semaglutide or oral semaglutide, so they should wait and bring this drug maybe. This is Mounjaro or tirzepatide. We know this drug is being used for weight loss. But about MASH, what is the role in MASH? If you see, the 15 milligram of tirzepatide results in 65% improvement in MASH as compared to only 10% in placebo. So again, this study is dealing with steatohepatitis and shows the role of GLP-1 agonists. Resmetirom is now available, and this is a drug that acts on the thyroid B1 receptors that are there in liver. But we should know that these receptors are not only there in liver, but these receptors are also there in pituitary gland also. So while we are prescribing these drugs, we have to be careful and monitor pituitary function as well. And this is a drug that improves the mitochondrial function, decreases the intrahepatic triglycerides, decreases the lipotoxicities, increases the fatty acid beta oxidation, and increases the cholesterol metabolism. All this helps in improving steatohepatitis and decreasing fibrosis. So this is a phase 3 trial, and there are different phase 3 trials, and all the coming under the umbrella of Maestro NASH program. And this shows that if you are using 100 milligram resmetirom and compare with the placebo, there is 30% of the patient after 48 weeks of or 1 year of treatment would show improvement in MASH or MASH resolution as compared to 10%, and there is improvement in fibrosis also when we are using this drug. So this fulfills both criteria, FDA criteria. One is MASH resolution and second is fibrosis improvement. So when we are prescribing this drug, we should know that the patient is having F2 or F3 fibrosis, because studies for F4 fibrosis are still not out. And we may ask for the fibroscan or velocity control transient elastography. And this patient should be between 8 kPa to 15 kPa. So if these patients are outside this range, then you have to individualize and use this drug off-label. We have to monitor for safety purposes and efficacy purposes certain investigations, including hepatic function, thyroid function, lipid profile, and then we have to have baseline liver stiffness, and if possible MRI PDFF, which is protein density fat fraction. So at the end of 12 months, you again assess your patients. If there is a beneficial effect, which is fibroscan improvement of more than 25% and improvement in ALT level, you may continue the treatment, because you will require long-term treatment with resmetirom. Otherwise, you may consider stopping or modifying your strategy. Lanifibranol is a pan-PPAR agonist. Again, this drug is undergoing evaluation, showing improvement in MASH score and improvement in fibrosis. Statins have their role in portal hypertension, not a direct role. And now these are the important group of drugs. These are the fibroblast growth factor 21 analogs. And one of these drugs is pegozafermin. And this drug, pegozafermin, if you see this drug has the efficacy profile much better than semaglutide in terms of fibrosis improvement and in terms of MASH improvement, and these results are much better than resmetirom. So before launching new generic versions of resmetirom, now companies should also think that these are the drugs that would soon be available, and some of the pharmaceuticals should start looking into these drugs that would have a better profile than resmetirom. So these are the different drugs. Because here we are dealing with multifactorial sort of metabolic milieu, and so we have to combine different approaches to treat our MASH patients. And the rationale is that if you are using resmetirom, it works, but it is not a drug to improve the insulin sensitivity. There are drugs like GLP-1 agonists. These drugs do not improve the fibrosis, though these drugs improve the MASH. These drugs may not be having lipid benefits that are maybe there. But if you see these drugs, pegozafermin, and pegozafermin is fibroblast growth factor agonist. This drug not only resolves MASH, improves the fibrosis, improves the sensitivity, and has got lipid benefits. So this drugs appears to be better than semaglutide and resmetirom. And here it does show that combination therapy is the future when we are using many of these drugs. And this is one combination that has been tried: semaglutide with cilofexor, and first stat combination. Semaglutide is a GLP-1 agonist, while cilofexor is inhibiting FXR receptor, acting on FXR receptor, and is agonist, inhibits the bile acid synthesis, inhibits the lipogenesis and neoglucogenesis, and fircostat inhibits the lipogenesis and increases the beta oxidation. So when you are using the combination of these three drugs, the response become better as compared to the single semaglutide. Here again, another fibroblast growth factor, efruxifermin. So fermin comes in all the drugs that are the fibroblast growth factors inhibitors, and this drug has been tried in MASH in patients with diabetes. So if you see here, these fibroblast growth factors, they have the better efficacy in terms of improving fibrosis. So much better than obeticholic acid, tirzepatide, or Mounjaro, or resmetirom, or semaglutide. So if you see the MASH resolution, again, these drugs that are the fibroblast growth factor agonist drugs, which is one of these drugs is pegozafermin. This is better in terms of improving MASH in these patients. So coming to end, and I consume my time also. So quickly, metformin should be avoided in decompensated cirrhosis when we are using this in our MASH patients because of the lactic acidosis. Sulfonylurea should be avoided in our MASH patient weight gain and risk of hypoglycemia in decompensation. GLP-1 we can use in child class A cirrhosis. SGLT2 inhibitors may be used in child class A and B. Statins may be used in cirrhosis of patients, cirrhosis, because they decrease the cardiovascular risk and decrease the portal hypertension, intrahepatic portal hypertension. About hepatitis E, vitamin E, and about the role of pioglitazone. Now the recent guidelines have dropped that from the recommendation. About GLP-1 and SGLT2 antagonists. There is role of these drugs in MASH also. PPAR agonist like pioglitazone may be used in individual cases. Saroglitazone, which is PPAR alpha and gamma receptor agonist, has been shown to improve, but most studies are needed on that. And about the resmetirom that is now available, may be used in F2, F3 fibrosis. And combination is the future that should be looked into because of the synergistic effects and more holistic treatment. And you can mitigate the side effects of individual drugs when you are using combination therapy. So personalized approach will allow for telling to the individual patients dominant driving factors. Thank you very much.
Thank you, Professor Zigam, for those insightful updates. Before starting on the next presentation, kindly, if there are any questions, you can send us via WhatsApp. That WhatsApp number is 032953999734. I repeat, 032953999734. So for our next speaker, Dr. Muslim Atiq, he will be presenting on hepatocellular carcinoma, current approach to management. Dr. Atiq is working as Chief of Gastroenterology at Shifa International Hospital, Islamabad. We welcome you, sir, for the presentation.
Bismillahirrahmanirrahim. I have to admit I'm a bit overwhelmed because I get to talk about hepatocellular carcinoma in the presence of some of the pioneers in the field of hepatology and transplant hepatology in the nation. So request to Dr. Saleh to not judge me on the content of this presentation. Having said that, a little bit about epidemiology. There's about 826,000 cases of liver cancer globally in 2018. Most of them were categorized as hepatocellular carcinoma, followed by intrahepatic cholangiocarcinomas, and then others. Hepatocellular carcinoma contributed almost 80% of the world total liver cancer burden, followed by others, etc. The bulk is mostly Eastern Asia. We being in South Asia, close to the East, contributing to the bulk of HCC globally. The causes, as we all remember or know, were viral hepatitis such as hepatitis B and C. However, now the trend is shifting more towards non-alcoholic fatty liver disease, now recategorized as MAASLD or MASH. From Pakistan, unfortunately, we do not have a population-based study as of yet. There is some nice work being done on this ground at the moment. However, based on the population estimates, the standardized rates for HCC is around 7.64 per 100,000 population males and 2.8 per 100,000 population in females, male to female ratio being almost 3.6 to 1. The usual age at presentation, and as we have seen in most of our practices, is around 5th and 6th decades. So when I was trying to get together a treatment strategy that could be a take home for all of us, I have to admit I had to really do a lot of digging. And it was a little bit different than what we do in a day-to-day life scenario. And of course, on top of that, 3 of the main strategies came out recently. So in 2022, the BCLC updated guidelines came out. In 2023, the American Association for Study of Liver Disease came out with their guidelines. And then, of course, in 2024, European Association for Study of Liver Disease came out with their guidelines. But the nice thing was they both kind of hinge on BCLC 2022. So BCLC 2022 is mainly the main fulcrum where the ASLD and AESL kind of put together their guidelines. So I'm trying to incorporate all of them to the best of my abilities and simplify and present to you a simplified approach that can be easy to practice on a day-to-day scenario. So when we talk about management of HCC, there are 3 main things we take into account. The liver function, of course, the tumor burden, but more importantly, the physical status of the patient, also known as the performance status. So this is the cornerstone of what we do in our day-to-day practices. Also, cannot overemphasize the importance of multidisciplinary meetings, MDT including a hepatologist, a surgeon, of course, a radiologist, a transplant specialist, oncologist, and ideally a pathologist. Now, we will just be discussing this. I just want to make a point to point out a couple of things here. So these are the BCLC 2022 updates. The most important addition to these updates were basically that now they take into account the prognostic factors based on the tumor burden, liver function, and physical status, refined by the alpha-fetoprotein, the LV score, the Child-Pugh score, and the MELD score, but also incorporate patient characterization to decide individualized treatment approaches. The rest of the stuff we will go through as we walk through the presentation. LB, albumin bilirubin gradient. And I just want to mention this simple score is a very relevant score when it comes to looking at the patient performance. We know that the LB correlates with overall survival in patients who are and progression-free survival in patients undergoing resection, transplantation, ablation, TACE, TARE, and then even those patients who are undergoing systemic chemotherapy. So this is kind of what this study kind of brings forth, the importance of LB in understanding the true underlying the tumor biology, if you will. Alpha-fetoprotein, we all know, but clearly this is a well demonstrated in multiple studies, but I just want to point out this is a database that basically mentions that alpha-fetoprotein in itself is a strong prognostic indicator for survival in patients with HCC, whether they are going for surgery, or whether they are not going for surgery, surgery was recommended but not performed, or even if the surgery was performed. So keep in mind LB and alpha-fetoprotein as 2 very important patient tumor-related characteristics. So now moving on to the treatment. I apologize, I had mentioned BCLC-A, but the very early, the BCLC-0, the gist of the treatment, like I said, I'm trying to simplify this as much as we can. The gist of the strategy is to check the alpha fetoprotein and make a decision about waiting or ablating. And if we look into the ASLD guidelines and we look at the HCC lesions that are less than 2 centimeter, also very early tumors, if the patient is a liver transplant candidate, then we go on to determine if the patient has decompensated cirrhosis. Then we go on to determine if the patient has alpha fetoprotein more than 100, in the range of 100 to 500. And if it is not elevated, then we can plan to wait and not ablate. Now this changes in the EASL guidelines. The EASL guidelines actually now recommend being a little bit more aggressive. They actually recommend that patients even with very early disease should be considered for ablation or resection. So I just want to point out the subtleties of differences in terms of the two guidelines that have been recently discussed. So now truly talking about the BCLC-A, surgical resection is the curative treatment of choice for patients with localized HCC in the absence of cirrhosis. Surgical resection can be offered to patients with cirrhosis but without portal hypertension. Now this is an interesting subtle difference between the ASLD guidelines and the EASL guidelines as well, because the ASLD guidelines mention a cutoff of around 5 centimeters for patients who have a cirrhosis. But the EASL guidelines actually do not mention any cutoff for patients who have cirrhosis, and they consider them still the optimum for surgical resection. Of course, if you have cirrhosis with portal hypertension, the answer is to go for a liver transplantation. Now coming back to this point about surgical resection that can be offered to patients with cirrhosis but without portal hypertension, in those patients, recommendation for surgical resection per guidelines must consider a multi-dimensional or what they refer to as a multi-parametric assessment of tumor characteristics and non-tumor factors such as degree of liver dysfunction, going back to what we had mentioned in the updated BCLC guidelines. So looking at the EASL guidelines, they mention taking a look at all the liver function related indicators, as well as the importance of looking into the future liver remnant, and they mention considering calculating CT volumetry of the liver. Then of course patient related factors such as age, frailty, comorbidities, etc. And a very important consideration that they specify and mention about the expected morbidity and mortality from that resection. So if the expected mortality is less than 3% and the expected morbidity is less than 20%, just only in those cases you should consider undergoing resection for that patient. However, regardless of these mentions, patients who have multifocal disease still within the Milan criteria are better served by liver transplant, as ablation and resection are hampered by a high risk of HCC recurrence. So what we mostly talked about was a single lesion, not a multifocal lesion. When it comes to multifocal lesions that comes within the Milan criteria, liver transplant is still the way forward. But is there still coming, quickly recapping the role of surgical resection in cirrhotic patients with BCLC-A? Again, I just want to mention that if it's a single lesion and the patient has cirrhosis, and even if the patient has portal hypertension, you can still consider surgical resection for those patients who are Child's B7, or you are not considering more than 2 segment resection. So if you are confining your surgical resection to less than 2 segments, or the patient's Child B7 and the expected mortality, which is hard to predict at times, is less than 3%, you may still offer those patients without portal hypertension the option of surgical resection. Never forget this. There is always an option to offer these patients surgical resection after downstaging. We often think that downstaging is often followed only by liver transplant. One of my patients recently underwent a resection after downstaging a few days ago. Always a good option. Never take that out of your toolbox. Is there a role for adjuvant chemotherapy after liver resections? An area of quite debate, quite an interest. The EASL guidelines at the moment do not recommend adjuvant chemotherapy for hepatic resections. ASLD guidelines, however, do mention consideration of adjuvant therapy in patients with high risk features, such as those patients with high alpha fetoproteins, poorly differentiated lesions on resection, final gross pathology, and those patients with multifocality. Now, this is where the magic happens. This is our Monday morning discussion, and I'm sure all of us have these discussions about which patients should go for surgery, which patients should go for TACE or other downstaging treatments, and those patients who should go for systemic chemotherapy right away. So BCLC-B is where the art of medicine supersedes the science of medicine. So BCLC-B is basically multifocal disease now, preserved liver function, no cancer-related symptoms with the performance status, which is very good, and no vascular invasion or extrahepatic spread. So the three options are either these patients go for a liver transplant, they can go for TACE or systemic therapy. And of the category, this is where most of the discussion happens. So BCLC-B and further characterized by EASL as well, basically talk about an extended criteria that is based on the size of nodule and alpha fetoprotein. Now, who defines this is what we're going to talk about, and this is per the guidelines to be determined by the institution in light of the current guidelines. If there is preserved portal flow with well-defined nodules, allowing selective access to feeding tumor arteries, and transplant for some reason is not an option, then we proceed on to do TACE, and then systemic chemotherapy, and of course, if there is diffuse infiltrative bilobar liver involvement. Just a quick minute about extended criteria. It basically considers those patients who are not fitting into the Milan the criteria. The survival may be comparative with that of patients with Milan, but always set at the cost of high recurrence and long long-term survival. Alpha fetoprotein cutoff is very important. More than 1,000 universally has been accepted as an absolute contraindication to liver transplants. Won't go into details, but to mention a few of those extended criteria, including the San Francisco criteria, the Toronto criteria, and then several others. This is where the role of downstaging comes in. Downstaging basically means applying locoregional therapy to downsize the tumors, hopefully to also decrease the level of alpha fetoprotein so that we can proceed on to resection or liver transplant. The UNOS downstaging criteria includes a single lesion 5 to 8 centimeters, or 2 to 3 lesions less than 5 centimeters, 4 to 5 lesions each less than 3 centimeters, and then they will further discuss the criteria for downstaging success and failure. Very important trial. I just want to mention in this trial the cumulative probability of successful downstaging at 6 months was around 68%. So almost 2/3 of the patients actually do have a successful outcome in terms of downstaging, and they come within the Milan criteria after locoregional therapy. This is our criteria at Shifa International Hospital, where we consider tumor size less than 10 centimeter. Any tumor number, alpha fetoprotein must be less than 1,000 when we consider them for transplant. So this is kind of a modulated institution-specific criteria based on the data that has been published. Want to summarize this whole discussion based on the EASL guidelines. For patients who are non-cirrhotic, if they can be resected regardless of the size, they should go for resection. Classically, ideally with minimally invasive procedures. If they're not resectable, locoregional therapy and then liver transplantation should be considered. Patients who are cirrhotic and they're resection candidates, solitary nodule, any size, and this is the difference. ASLD makes the cutoff at 5 centimeters. EASL does not give you a side category cutoff. You should go for resection. Less than 3 nodules, less than 3 centimeters, resection, but ideally liver transplant, ideally resection. Multiple nodules, you should go for liver transplant. I apologize, downstaging followed by resection. Just want to spend a minute about the progression. So there's a new definition for BCLC progression. Basically talks about those patients who move from BCLC-B to progress on or go and further move on to BCLC-C category. So they have characterized this here. If you have growth of more than 20% of existing nodules or new intrahepatic lesions, and you can go and you had BCLC B at baseline, you can go on to progressive BCLC in B2B category, or if you had BCLC C at baseline, you can go on to C1 category. This is where the problem is. If you have no extrahepatic lesions or angio invasion, now you are BCLC P C2. Why is this important? Because it defines our therapy. So the rest we have discussed, but I just wanted to mention, if you go into BCLC P C2 category and now you have vascular invasion or distant spread, you assess for systemic chemotherapy, and unfortunately the ship has sailed. BCLC-C, as you would expect, you talk about advanced stage, and unfortunately the mainstay of therapy is now systemic therapy. The mainstay of therapy in terms of systemic therapy is immunotherapy. The main contraindications for immunotherapy are autoimmune disorders, liver transplantation, no contraindications and high risk for the, you have to see if these patients have high risk of GI bleeding. If they're not at high risk of GI bleeding, you should consider atezo and bev. Please make sure you do a screening endoscopy beforehand. You'll be surprised how many times you'll be finding high risk stigmata and they will need further intervention. If there is a contraindication immunotherapy, then you can consider the therapies such as sorafenib, lenvatinib, and so on and so forth. So I will now summarize the best. Like I mentioned, multidisciplinary discussion is key to decision-making in hepatocellular carcinoma. Very early stage, less than 2 centimeter, can either wait or ablate. Like I mentioned, as per EASL, now they are moving more towards an aggressive approach and recommending ablation or resection rather than waiting. Early stage, single or less than 3 centimeter, 3 lesions, ideally should go for resections, but transplant is also a possibility. Intermediate state is where the magic of transplant happens. They can undergo liver transplant with expanded institution-based criteria, like we mentioned ours, local regional therapy with TACE or systemic therapy. For advanced stage, especially with the portal vein invasion, you should consider systemic chemotherapy. For terminal stage, end-stage liver function should be managed by best supportive care. I thank you for your attention.
Thank you, Dr. Muslim Atiq, for the informative session. Let us welcome Professor Kashif Malik, who will give us the current updates on hepatitis C management. Professor Kashif Malik is working as the head of department at Sheikh Zayed Hospital, Lahore. Please welcome, sir.
Bismillah ar-Rahman ar-Rahim. Thank you, Noman. First of all, I would like to thank you, Pakistan Society of Gastroenterology, specifically Professor Sherrahman, Dr. Kamran and his team for arranging such a nice and successful conference, and we really enjoyed our stay here. So the topic given to me is chronic hepatitis C management current update. Because the thing is, there is no new drug came for the treatment of hepatitis C right now. So I would like to touch some other points of current update regarding hepatitis C management. My first slide is for our brothers and sisters who are basically in trouble in Palestine. Please show solidarity with these people because they are our sister and brother and they are in real difficult time. So today also is the World Liver Day, so this session will go along with this to celebrate World Liver Day. So same to start with, just an introduction that as everybody knows that hepatitis C is an infection caused by hepatitis C virus, and if untreated causes liver fibrosis, cirrhosis and hepatocellular carcinoma. And across the world, 58 million people worldwide has living with chronic hepatitis C. In Pakistan, around 12 million people still are waiting for treatment because our speed to treat this deadly disease is quite slow. Investigations, as mentioned, that anti-ICV is a screening test for our trainees and the other GPs, that there is no role of anti-ICV once it's positive to look for the progression of disease. It's just a screening test which either you do while checking for some other reason, and if it is positive, according to the literature, it will remain positive in most of the people. The other tests, the CBC, LFT, RFTs, are for initial assessment, and for monitoring we use it. The test which tells you that hepatitis C is active in the body is the hepatitis C virus RNA, the PCR test commonly known. And initially we do the qualitative, but now the recommendations are, because I took this data from AASLD guidelines, so they recommend the quantitative PCR should be done in this patient to confirm the infection. And other important thing is the abdominal ultrasound, and to check for the FIB4 or the APRI score. The rest of this liver stiffness measurement, this is in selective cases. Also the genotype is only for selective cases. And liver biopsy is in very, very selective cases. So three component of this hepatitis C management are the pre-treatment assessment by PCR, liver fibrosis stage and comorbidities, on treatment assessment, and then the post-treatment follow-up to look for SVR to complete to look for the eradication of this particular disease. WHO has given us the task to eliminate this disease by 2030. There are barriers in our society. The first is access to the testing and treatment. This is the most important thing. Most of our people, they cannot reach to the actual person or the institute to get their assessment for that hepatitis C and for the treatment. And the second thing is, which is also very common, and that is a stigma and awareness regarding this particular disease. But now, over a period of last 20 years, I have seen that now patients are concerned about it, because this disease is usually in families, and when they see somebody is suffering from disease and they lose that particular person, so the family is then afraid of having this disease, and now they are contacting. The second thing is the treatment algorithm is quite simple now, and so people are opting for the treatment for hepatitis C. And the third thing is the cost consideration and healthcare policies, which is also a major problem in our society to deal with this particular problem. So the current guidelines, the treatments available are, the first one is that's Fasovir and Valpartisavir. This is the cornerstone of this the treatment of this particular disease, because in our setup this is now freely available, and this is cost effective. The other one, this is the duration is only 8 weeks, but this is, honestly speaking, I haven't treated any patient in my practice with this particular drug. This Fasovir with Ladipasavir, that was genotype 1 specific, and we initially used in genotype 1, but with the availability of Fasovir and Valpartisavir, soft Velpa, we are not using this drug. This another drug which is not in the guidelines of these societies, but in our setup, when it was introduced, in the government sector, there was we found this drug available, and we have treated hundreds of patients with this drug, and that was quite effective to achieve SVR in the patients. So still, if this drug is available free of cost, we are prescribing this drug to our patients. And then comes this drug, the soft Velpa with Valoxapravir, that by the name of Vasovi, and this is for relapsers and non-responders. 8 to 12 weeks we are using it for the relapsers. This drug was initially available, and everybody, I think, have written it, prescribed in 2014 to onward, but it is now no more recommended that you give Fasovir and Ribavirin, the famous Sovaldi and Rabazole, that should not be prescribed to the patients, because they have high relapse rate in a patient having this. Ribavirin is a very good drug we can use in patients, particular patient with cirrhotic patients or with relapses, this drug has a major role in to achieving SVR in these patients. This is a simplified treatment algorithm just with the availability of pan-genotypic DAs. AASLD guidelines have given this simplified treatment algorithm patient without cirrhosis or with compensated cirrhosis in 2019. And this simplified features reduced pre-treatment and on-treatment clinician intervention and expanded eligibility of person who can be treated using these approaches. So doctor-patient interaction is reduced in this, and on-treatment follow-ups are also been reduced, just minimizing the cost of the treatment, and a minimal on-treatment monitoring is also been done because these drugs have very less side effects, and only in selective patients we need a strict follow-up. Who is eligible for this simplified HCV treatment algorithm? Adult patients with chronic hepatitis C infection, including HIV, are infected with any genotype because pan-genotypic drugs are available, and who are naive patients and without cirrhosis or with compensated cirrhosis. Compensated cirrhosis can be checked by liver stiffness if it's more than 12.5 on fibroscan, FIB4 is high, or there is sometimes the liver biopsy being done and shows cirrhosis, or even the on ultrasound if you find a nodular liver along with splenomegaly without SOL, so that can be labeled as a compensated cirrhosis. And platelet count is also very important. And who is excluded from the simplified HCV treatment algorithm? Patients with relapsers having have taken the treatment for hepatitis C, co-infection with hepatitis B, or compensated cirrhosis with end-stage renal disease. Because if the eGFR is less than 30, patient is having end-stage renal disease, these patients should not be put on this simplified HCV treatment algorithm. Along pregnancy and suspected hepatocellular carcinoma and patient having liver transplant. So if we see the pre-treatment assessment, as said, calculate FIB4, assess for cirrhosis, get CBC done, hepatic functions, eGFR, which we commonly do, CBC, LFT, RFT is being done, so that can be done. So FIB4 can be calculated. Check for the PCR and also for hepatitis B surface antigen. Pregnancy test should be done in patients having young patients, and educate this DA administration, adherence, prevention of reinfection, avoiding excess alcohol. On treatment monitoring, patient or diabetic patient should be warned about having hypoglycemia while using these drugs. The other one is for people who use warfarin, and they should this drug has an interaction with these drugs. Otherwise, rest of the patient, you don't need any monitoring. And to avoid regular visits or frequent visit, either go with a telehealth or for phone visit, as we are using WhatsApp for this. Patient's symptoms and support can be symptoms can be assessed and support can be given. So post treatment, you have to check for the HCV, RNA, PCR by PCR and hepatic functions after 12 weeks following the completion of treatment, not at the end of the treatment. They recommend to cut the cost, and you have to check for SVR 12 weeks after completion of treatment. And if it's undetectable, so then it confirms that the patient has got SVR 12. And if the patient's LFTs are still high, then look for other causes of this deranged LFTs. Post-treatment follow-up is the advice regardless of the cause, alcohol should not be used. If cure is achieved, patient is non-cirrhotic, just have chronic hepatitis, no follow-up is recommended for non-cirrhotic patient. If the at the high risk of reinfection, consult on risk reduction and test for HCV annually or with elevated if the patient is having elevated ALT and AST levels. But if cure is not achieved, refer to the specialist HCV treatment until retreatment. Assess the disease progress every 6 to 12 months with the hepatic functions panel, CBC and INR. So this is the simplified algorithm. for the non-cirrhotics and patients, or but with the cirrhotic or compensated cirrhotic patients, everything is same except this area. Perform ultrasound or alpha fetoprotein every 6 months for hepatocellular carcinoma surveillance, advise abstinence alcohol, and evaluate for varices as per guidelines. And same is for that if the risk is infection is there, repeat the test frequently, and if not, if SVR is not achieved, then keep the patient on regular follow-up or refer to some specialist for retreatment. This is another issue because management of incomplete adherence to the our patients, some of our patients, they stop taking medication because of any reason. So there is a guideline. If the interruption before receiving 28 days of therapy, the guideline says that restart less than 7 days, missed for less than 7 days, restart DS therapies immediately, complete therapy originally as planned, either 8 weeks for GP or with soft Velpa for 12 weeks. More than 8 weeks, restart therapy immediately, but he said just check a HCV RNA at the time when you're starting the treatment. If the HCV RNA is negative, complete original planned DS treatment, that is 8 to 12 weeks total dose, or extending the treatment. This is one thing. They say if in genotype 3, even if you get the PCR done that is negative, go with another month of treatment, that is 4 weeks of treatment to infection or in the compensated cirrhosis. And if the HCV RNA is positive or not obtained when you restart the treatment, DS treatment, again for the 4 months treatment is advisable. The other side, if you have the patient has already taken treatment for more than 28 days, and then if missed for 7 days, restart therapy immediately, complete DS for originally planned duration, that is 8 to 12 weeks. But if the patient has 8 to 20 days missed, restart DAs immediately and check for the PCR at the same level. If the PCR is negative, undetectable, complete the original dose, that is 8 to 12 weeks, and the recommendation again is additional 4 weeks if patient is having genotype 3 or have compensated cirrhosis. Because we have patient, most of the patient, our patient has genotype 3. So in our setup, they according to these guidelines, one should have to complete 4 months of treatment in this patient. That is 16 weeks. If HCV RNA is positive or not obtained, stop treatment and restart according to the recommendation in the retreatment section. But if the missed for 21 consecutive days, stop the treatment. And we have seen this. So DS and check for SVR. If not achieved, then the recommendation is to retreat the patient, because we have seen patients who have taken medicine for more than 28 days, maybe 6 weeks or 8 weeks, and they stop. Sometimes they get the SVR, they achieve the SVR, so there is no need to retreat these patients. So, but if the PCR is positive, then they are the candidate for treatment as a relapser. So what is these are special populations: relapsers to DS, patient with cirrhosis, compensated versus decompensated, chronic hepatitis C in children. These are few special population topic which I will discuss in next 4 or 5 minutes. Phosphobir based regimen failure, chronic hepatitis C without cirrhosis, retreatment with SOF, Velpa, or Voxiplavir, that is Vasovi, for 12 weeks. So chronic hepatitis C with cirrhosis, retreatment with SOF, Velpa, Voxi plus Ribavirin. If cirrhosis, then add Ribavirin, and that is for 12 weeks. Or if there is no cirrhosis, Vasovi alone will work. And extended treatment with SOF, Velpa, can be given. If this is not available, that another 12 weeks can be given. That is 24 weeks treatment can be offered to these patients. And if you have failure or relapse to this Vasovi or this GP along with Phosphobir treatment failure, then if with the SOF, Velpa and Voxi, then you have to go with the this GP along with fosfovir and weight-based ribavirin for 16 weeks. But if the relapse is to GP along with that, so then you have to go with fosfovir, the Vasavi, along with the ribavirin for 24 weeks. Compensated versus decompensated. These drugs not be given in the setting of decompensated cirrhosis. So retreat with the 24 weeks course of either SFAS, Tasavir along with ribavirin and or ledipasavir, fosfovir plus weight-based ribavirin. And SVR rate is almost 91 to 100% in these relapsers. In children, they have now suggested that recent studies about 3.6 million are living with HCV infection, 2 pan-genotypic regimens, that is GP and fosfovir and Velpa for children as young as 3 years can be prescribed for the same duration, that is 8 to 12 weeks. In hepatitis C infection is not advisable to treat during pregnancy, but they have given the guideline that every pregnant woman should be checked for hepatitis C, and only in the special case-to-case basis, if required, one has to go with the hepatitis C treatment. In co-infection, if the patient is having hepatitis B virus DNA positive and eligible for treatment of hepatitis B, start nucleoside analog and continue along with the treatment of hepatitis C. If HBsAg is negative, but because of previous exposure, anti-HBc IgG is positive, monitor for reactivation. And the dose is same and duration is same with hepatitis B negative patients. Then this is a very important thing, that the CKD patients with or without hemodialysis. Any DAs can be given in CKD 1 and 3 on standard regimen. But CKD 4, GP is more preferable as compared to soft fosfovir. But in our setup, we are giving it because we don't have this other drug. So the results are encouraging in this. The problem is with the CKD 5 patients on hemodialysis. Because we have seen this, that their relapse rate is very high. Both drugs are safe and can be given, but relapse rate is very high in these patients. Then the transplant patient, that is basically they have given, if you give donor is positive and the recipient is negative, but usually we do not do this. This is for the cadaveric if you get a transplant organ from the positive patient. So that is guidelines for this. So the other one is again same is soft Velpa can be given in these patients. So I conclude here that the pan-genotypic DAs are the cornerstone of the treatment with SVR rate more than 95%. Relapses to DA need special attention. Management algorithm for non-cirrhotic and cirrhotic patients is same except to keep cirrhotic patients on long-term follow-up. Universal screening is advisable for all pregnant women. DAs can be prescribed to children aged more than 3 years. A treatment can be offered to patients with CKD and solid organ transplant. And high SVR can be achieved with an early diagnosis and treatment. So the reference is the AASLD guidelines. So I thank you all for listening. And if there is any question, I'm available after the session here. Thank you.
Thank you, Professor Kashif Malik, for the comprehensive overview. Now I invite Professor Javed Iqbal Farooqi to talk on how to improve the quality of life in decompensated cirrhosis without transplant. Professor is working at Life Care Hospital and Research Institute as the head of department. Welcome, Professor.
Thank you, Dr. Naman, for your kind introduction. I have my slides? Yeah. Thank you, organizers, once again. Khalid bhai, Kader bhai, Malik bhai, इंतजार कर रहा था. Khalid bhai उमन आते नहीं है. Thank you very much, क्या पाए. Well, greetings from my institution to all of you. The topic assigned to me is the decompensated cirrhosis, how to improve quality of life without liver transplant. And Khalid will agree with me, this is the everyday scenario for us. Every one of you probably will agree with this. Ijaz bhai, thank you very much for coming here. Well, in the next 20 minutes or so, don't expect me that I'll be giving you some new data or something new. What I'll be trying to put the pieces together for you. Whatever knowledge you have, I'll try, especially for my junior colleagues, that you apply that info, that understanding in a way so the benefit goes to the patient. Chairpersons, allow me just 2 or 3 minutes for my junior colleagues to share with them the basics, how the liver is transformed from the normal liver to a cirrhotic liver. The normal liver, the green, cirrhotic, the blue. We know the cirrhosis is a compensated to decompensated stages, and the compensate is further divided into two, without varices and ascites, and second stage of compensated cirrhosis, varices but no ascites. And then it's a decompensated when the varices bleed or ascites develop. This is technically decompensated cirrhosis, and I have been asked to share with you my way how to improve the quality of life in this group. Remember, this is all the game of portal hypertension. In the chronic liver disease, non-cirrhotic stage, this is when the HVPG is less than 5, and in the cirrhotic stage, whether compensated, decompensated, this is more than 5. But depending upon the stage, when it is 6 to 10, this is the compensated stage 1, where there are no varices and no ascites. But when the pressure rises more than 10, this becomes the clinically significant. From 11 to 12, the varices develop, and about 12, the varices rupture. These are the basic facts you should remember in your mind when you treat such patients. Then the hepatic encephalopathy. In the non-cirrhotic stage and in the compensated stage, it appears as a part of the ACLF. Shasa will be talking on this in his lecture. And in the decompensated stage, HE develops as a consequence of liver cirrhosis, and then the HCC. Even in the non-cirrhotic stage chronic liver disease, there is a risk of HCC, especially hepatitis B, the MASH. Then in the compensated cirrhotic stage, again, these patients are at risk, but when the patient is decompensated, the risk is at its maximum. We all know that these are our basics. So, cirrhosis is a progressive disease having the 4 stages: non-cirrhotic chronic liver disease, compensated liver cirrhosis, decompensated highlighted red, and the end stage liver cirrhosis given the color of black. Remember this color coding. This will be helpful to understand what I want to communicate to you. In the non-cirrhotic chronic liver stage, it's a normal lifespan. In the compensated, median survival of 12 years. While in the decompensated stage, the median survival is reduced to 2 years, and in the end stage liver cirrhosis, it is median survival 2 months or even less than that. We know the non-cirrhotic chronic liver disease stage, this is asymptomatic, and liver transplant may be needed when the HCC develops or ACLF develops. The same is the compensated liver cirrhotic stage. By and large, asymptomatic phase. HCC develops, ACLF develops, liver transplant required, otherwise no need for liver transplant here. This is the decompensated stage, when the patient has ascites, bleeding, episodic HE, or jaundice because of the ACLF, or the HCC develops when you need liver transplant for these patients. And the last stage, so many complications, the refractory ascites, SBP, so many. So this is the way. The point is that in the non-cirrhotic chronic liver disease stage, quality of life is normal. In the compensated liver cirrhotic stage, good quality of life. This is the decompensated liver cirrhosis, when the quality of life is really poor, and in the end stage, this is the miserable quality of life. Knowing this is the chart. This is showing the morbidity and mortality, and this is the time. In the compensated cirrhotic stage, almost patients are having normal life. This is when the decompensation happens, and within 2 years we lose the patient, and this is the black is the terminal. Liver transplant is required as a natural decompensated stage when the patient reaches this stage, or if a patient develops HCC here or ACLF here, liver transplant will be required. And I have been asked that in this stage, when the liver transplant is required and the patient cannot have liver transplant, how to improve quality of life. Okay? Well, the quality of life, just a word or so. WHO defines individuals' perception of their position in life in context of the culture and value systems in which they live and in relation to their goals, expectations, standards, and concerns. But we are discussing and it has got multiple domains, health-related, and so many. And I've been asked to share with you how to improve the health-related quality of life. Different questionnaires, I won't go into the detail of that, the European, the general. But point is, and I'm not going to discuss these with you, studies have shown that cirrhotics, they are very fragile creatures, individuals, fragile population, needs special care, and you need, if treating these patients, to identify the challenges these patients have and to treat those challenges in time. Well, this is the patient I want to share with you. He came to me from my village a couple of months ago, and he presented to me this time with ascites. When I digged into his record, when me and Khalid were teamos, at one time he had come for this surveillance endoscopy, and so this was, and that was 1999. There were another 1999, another report with him. Further digging the documents, in 97, when so many of our seniors know they are retired, and at that stage, then further digging into that, very interesting. Alif Khan Saab professor, our Sadiq Shah Saab, our mentor, he was associate professor. And he's coming. Reason of admission is bleeding and surveillance endoscopy. Going back, this 1990, probably we are doing the house job. Khalid Saab was doing the house job. I just completed my house job. Shah Saab was going to get his Young Clinician Award from the World Congress of Gastroenterology. It is back, sir, 1990. So, you see, this patient coming to me, he was not my direct patient, just the record told. And he said, sir, diagnosed in 1990 is a decompensated liver cirrhosis, admitted for bleeding. And 2025, 35 years. 35 years, more than 50 endoscopies done with interventions, still alive. I'm not saying each and every patient behaves like this, but there are patients, and if the patients are followed properly, they can behave like this. So question for you is, how has been his quality of life improved and maintained without liver transplant? So we'll come to this later on. This is we presented in 19 2016, almost 9 years ago, the data in the puzzle of our 2,700 cirrhotic patients, and they presented first time to us, to our center. Most of them, they were in child class A, good shape, and those who are having complications, this was the list, we know all that. But less than 1% could afford liver transplant. This is the reason I think this subject is close to my heart as well, and thanks to Kamran, he told me, sir, I want to give this topic to you. I think this is very, very important. So what's our policy, or what's my way of approaching them, probably most of you as well? In such patients, improving the quality of life in patients with decompensated cirrhosis when liver function significantly declines and complications arise requires a comprehensive multidisciplinary approach. We all know that. Liver transplant remains a definitive treatment. Many patients are not candidate or may need symptom relief while waiting. Our patients are very poor. So believe me, out of those 2,700 patients, only less than 1% could afford transplant. If I ask Khalid भाई कि बताएं आपके कितने मरीज ट्रांसप्लांट में गए, शायद उंगलियों पे गिन के दे देगा मेरे इतने गए हुए. The same can be. So points we should remember in our mind while improving, trying to keep them alive and improve their quality of life is optimized medical management, nutritional support, lifestyle modifications, psychological and social support is very, very important. Palliative and supportive care is very important. Manage the comorbidities, physical activity, and frequent follow-up and multidisciplinary care. I can't go into detail of each and every point, but for the optimized medical treatment, we need to care of the ascites, the low sodium diet, diuretics, at times the tips. Tips is again a luxury for us. Then for the hepatic encephalopathy, again, the lactulose, rifaximin, all we know that protein intake should not be overly restricted. This is a problem which I see, and probably Khalid and we all see, that un pe gosht aisi ban kar de jate, it should not be like that. And addressing precipitating factors. Again, varicose bleeding, another scenario of this very patient was coming for endoscopies for varicose bleeding surveillance. Then the infections, don't forget to take care of the infections, the SBP and other infections. Similarly, regular monitoring is very important. I was just checking, couple of my patients, a good number of my patients, they had more than 140 visits with me. I'm the regular surveillance, so it should be. Then the ultrasound, imaging, surveillance for the HCC, these all are very, very important. Nutritional support, don't forget to restrict the protein. They are sarcopenic. They may be obviously showing that they have got good BMI, but it is the false BMI, they're sarcopenic. Then the protein intake should be ensured. And of course, the caloric needs should be ensured, the minimum they should take. And of course, don't forget the vitamin supplementation given to these patients. Macronutrient supplementation is very, very important. Lifestyle modification, these are again very, very important. Alhamdulillah, here the alcohol is not that high, but the hepatotoxic drugs, please ensure that they don't take hepatotoxic drugs and vaccinate against hepatitis B, HIV and HEV, the influenza, the flu vaccine. Psychological, social support is very important for these patients. Similarly, palliative care, they may need at times the symptomatic control of pain, fatigue, and all those things. Similarly, the comorbidities, most of these patients, especially the elderly ones, they have got hypertension, diabetes, renal dysfunction, so take care of those as well. Similarly, the physical activity, ensure a good physical activity in these patients. Don't let them to bas bistar pade rahe aur kahe hum to hil jul nahi sakte. The physical activity in itself, it reboots your system, your body, so this is very, very important. Toilet exercise program, especially to help their sarcopenia, is very, very important. Similarly, the frequent follow-ups. Follow-up is the key in these patients, and you should not forget that if the follow-up are not there, probably you will lose the patient. So when transplant is not an option, Frailty, advanced age, cancer, socioeconomic barriers. This may be one of the factors that you cannot refer these patients for transplant. Need for parallel planning, treatment, and comfort. This is very, very important. Symptom management focus. You should focusing on the symptoms: pain, fatigue, pruritus, anorexia, sleep disturbances. Avoid polypharmacy in these patients. Consider antidepressants and anxiolytics if appropriate. There was a study on the quality of life, the European quality of life, and those who were having good sleep, they were having good quality of life, bad sleep, poor sleep, bad quality of life. So this is very important. Psychological and social support. This is again very, very important. Don't forget, depression, anxiety, cognitive decline is common, and you should address these. Role of caregiver support, social workers, psychiatric referral. In those family, at least you educate one or two people who can take care of their patients. Palliative care integration is very important. A time may come where these needs the palliative care, hospice care for these patients. This is very, very important. And don't forget that multidisciplinary and holistic approach is the need for these patients. Pathologist, GP, dietitian, psychologist, social worker. Don't think that each and every patient will be coming to you as a gastroenterologist. Most of them, they go to the primary care physicians, they went to the others. So this is, you should be even educating the people, the primary care physicians in your locality to take care of such patients in a better way. So these patients, when they come to us, they come with the acute event. So the acute event has got three components: treat the primary decompensation, treat the secondary complication, and prevent tertiary complication. Then is the second stage of prevention of future events, secondary prophylaxis, primary prophylaxis, varicose bleed, ascites, HE, all that. You know that I wanted to just put your knowledge in a proper way so the benefit goes to the patient. And of course, the essential components are all these 7, 8, 9 steps which I discussed with you. And don't forget that this is the multidisciplinary team approach where the best care goes to the patient. So coming to my patient, how has been his quality of life improved and maintained without a liver transplant? Anybody? फीजीज 35 साल गुजरे, अभी तक बंदा जिंदा है, ट्रांसप्लांट नहीं हुआ. You know, cirrhosis has got, it's a multi-faced, multifaceted disease. कभी एच के साथ आया, कभी ब्लीड के साथ आया, कभी किसी और चीज के साथ आया, कभी उसके 2 चेहरे हैं, 3 चेहरे हैं. इट में किसी कॉम्प्लिकेशन के साथ आया, प्राइमरी डिकम्पोजिशन तो आपको ट्रीट करना ही करना है. लेकिन डोंट फॉरगेट कि सेकेंडरी कॉम्प्लिकेशन, ब्लीड के साथ आया, एच में चला गया, शॉक में चला गया, और साथ में टर्शियरी कॉम्प्लिकेशंस भी आपने बचानी है. तो एज अ होल पैकेज आपने इस पेशेंट की तरफ जाना है. सो 35-year story of success, key lies in regular follow-ups and monitoring and in time troubleshooting. So the key takeaways: liver transplant is not the only path. Quality of life can be improved even without this as well. Focus on symptom control, nutrition, mental health, and support systems. Early multidisciplinary intervention makes a measurable difference. And with this, I thank the organizers and you as well for giving me the opportunity to share with you what we are dealing with such patients on everyday basis. Thank you very much.
Thank you, Professor, for the thought-provoking discussion. Before that, all the members of the PSG who have pending membership clearance issues or any related issues regarding membership can meet Masroor in the sitting in the registration area. So, our next speaker, Dr. Ehsanullah Haq, who will discuss liver transplant, current status and challenges in Pakistan. Dr. Ehsan is working as the head of department HPB and liver transplant unit at PKLI Lahore. Please welcome Dr. Ehsan.
Bismillah ar-Rahman ar-Rahim. First of all, thanks to PSG for inviting me in this presentation. And I think it's a great honor for me and my team to be a part of this gathering. So my topic of presentation is liver transplantation, current status and challenges in Pakistan. There was a time when liver transplant facility was not available in this part of the world, and the only option patient had to go overseas to get their transplant done. But remember, this facility was only available to those who were filthy rich in terms of finances or those who were sponsored by the government. And most of the patients, they lost their lives because they could not afford the expenses of liver transplantation. And still I remember the day when I was in medical school, and one of our close family friend landed in our facility with acute liver failure, and we were planning to make our referral documents for her to send her overseas to get her transplanted. But unfortunately, she died because of the complication. So let's see how common liver cirrhosis is in this part of the world. Liver cirrhosis and liver-related disease, they are now a severe and major problem in this part of the world. According to World Health Organization, a majority of the patients who have this liver cirrhosis and liver-related diseases, they are dying in this part of the world. And according to World Health Organization, you can see this slide is taken from World Health ranking, and we are now among on 29th number in the world rank in terms of having a liver cirrhosis, liver-related diseases, and liver-related mortalities. So you can imagine how common this disease is in this part of the world. And now we are labeled as a cirrhotic nation. Being the most common cause is hepatitis C, which led to end-stage liver diseases and HCC. Hepatitis B, which is the second commonest cause of end-stage liver disease, and HCC, which is relatively common in those who are young. And as per our experience, hepatitis B is more common in the South Punjab and some district of Sindh and Balochistan. Other liver diseases, interestingly, major chunk of this other liver diseases, which were previously labeled as cryptogenic liver diseases, if you dig into it, they all fall in the category of MISLT, which is now a growing problem, not only on the recipient side, but also we are facing this on the donor side as well. Total population of Pakistan is around about to 40 million with 12 million infected population. And 20% of the 12 million, 20% of the 12 million, which is 2.4 million, they will end up with end-stage liver disease and HCC. And this 2.4 million, they will need a liver transplantation at some stage. So what's the growing demand of liver transplantation in Pakistan? Because the disease prevalence is very high, I mentioned earlier that we are now on 29th number in the world. 2.5 million population, they will need a liver transplantation at some stage. Remember, liver transplantation facility, which is limited in this part of the world, and the average demand to have a liver transplant is between 7,000 to 9,000 and maybe more than that. And right now, the maximum number of transplant, if you calculate them, I mean in all the transplant facility in the country, so the maximum number of transplant performed per year in Pakistan is 600, maximum up to 700. So looking into the history of liver transplantation, Professor Thomas Tazel, he's the father of transplantation. He did the first liver transplant in 1963 on a 3-year-old child with biliary atresia. Unfortunately, that child died during surgery due to complication. And then he did the first successful liver transplant in 1967 on a 19-month-old girl with hepatoblastoma. And this patient survived for 1 year time. And then the race of living donor liver transplant starts. Majority of the initial liver transplant, living donor liver transplant, they were performed in a pediatric population using a left lobe graft. The first successful living donor adult liver transplant was performed in 1993. And if you look into the history of liver transplantation in Pakistan, so the first liver transplant in Pakistan was performed by SIUT team with the collaboration of King College Hospital liver transplant team in 2003. And then there was a deep silence for almost 7 years. By the time a local transplant team from Sheikh Zayed Hospital, they performed the first cadaveric liver transplant. And I think this was a time for them to celebrate this historic achievement. But according to the team, they were heavily criticized by doing this, by wasting all the hospital resources just by doing a single transplant. In 2009 or 10, Professor Dr. Faisal Dar, he joined Shifa as a transplant center, and according to him, there was a lot of negativity and criticism about him and also about the liver transplantation. So he established a liver transplant team in PKLI with the help of Dr. Najam and Dr. Saleh, and he did the first liver transplant on this 11-year child. I think his name is Yasin, and he is still alive. So Dr. Faisal Dar, he is the pioneer of liver transplantation in Pakistan. He trained a lot of surgeons in this field who then start living donor liver transplantation in different facility in the country. So this is the transplantation tree in Pakistan. As I mentioned, the pioneer of liver transplantation, Professor Dar, almost 98% of the transplant center working today in the country is because of him. So he started a transplant in Shifa, and then the teams started a liver transplantation in PKLI in the Gumbert Institute. So as a part of PKLI mission and vision to promote culture of education and training, PKLI helped Qaidazm, the Dow team, the military hospital in terms of establishing liver transplant facility. And the Dow team, they are now doing a liver transplant in Ziauddin and SIUT as well. And recently, we have signed an MOU with the Mukhtar Sheikh Hospital. It's one of the biggest facility in the South Punjab. In a month, 2 time, we are going to start a liver transplant there as well, inshallah. So how many liver transplant centers in the country currently doing liver transplants? So we have 4 centers in the Sindh, including the Gumbert, the Dow, Ziauddin and the SIUT, and 4 centers in the Punjab, PKLI, Sheikh Zayed Bahria, and the military hospital. And we have 2 centers in the federal government. This is the data of liver transplantation in Pakistan, the first 4-year data of liver transplantation. And you can see majority of the transplant, they were done at the Shifa facility, followed by Sheikh Zayed Hospital. With the passage of time, more people get trained and they start working in a different institute. So this is the data of 14 years of liver transplantation in Pakistan. The total number of transplant which were done in the last 14 years, 4,284. So Shifa is on top, followed by the Gumbert Institute and PKLI. So the 808 is now 890. So soon we are going to celebrate this 900 figure, inshallah. So if you compare a liver transplantation with our neighbor, India, currently they are doing 2,000 transplant per year. It's just the living donor liver transplant. And they have 90 to 100 liver transplant center. So we are far away from them at the moment. So what's the demand of liver transplant in Pakistan? So if you keep it simple and you divide the 9,000 liver transplant into different numbers, and you do it in a way that 150 transplant they should be done in a transplant center. So the number of transplant we needed in the country is between 10 to 15 liver transplant center in each province. So we are still far away from our target. So let me briefly tell you the history of liver transplantation journey in PKLI. We did the first liver transplant on this young gentleman, Mr. Nadeem, a 42-year-old. In 2019, we did the first transplant. Total number of transplant so far we have done is, this figure is now 890. And we did the first pediatric liver transplant in 21. And this was a historic moment in the history of Pakistan. And this was the second cadaveric liver transplant in Pakistan. So we did this transplant with the help of UAE government. The organ was transported by a special jet from UAE. And this transplant was done. So this was a historic moment for us. Total number of transplant, as I mentioned, we started our transplant journey in 2019. And you can see a gap there as well. So one point which I want to mention here, if you have a strong administrative support, even then you can achieve your target. So there was a time in between 2019 and 20 that the hospital administration called me that, Dr. Hassan, don't be emotional. If you are doing one transplant per month, so we are okay with that. And then once the administration changed and the new administration called the team that, listen, a liver transplantation is a flagship program of this institute, and we need to have a more transplant. And the only survival of this institution is by doing more transplant. So we did a 259 transplant in a single calendar year. And this was a historic day for us when we crossed the figure of 251. This is our team of surgeon, transplant physician, and anesthetist. So this is a brief summary of what we are doing in terms of liver transplantation. So total number of transplant done so far, 890. We are the only center in the country, alhamdulillah, who have done 103 pediatric liver transplant. We are also doing swab liver transplant, a 3-way exchange liver transplant. This means you are doing 3 transplant at one time. So this was, again, first time in the history of liver transplantation. So we are also doing auxiliary liver transplant, especially in the pediatric cases. And our training program is recently recognized by the CPSP and MS as well. So we have total 17 trainees. And interestingly, 7 of them are from KPK. So why not a liver transplant facility in the KPK? Disease burden is high as the rest of the country. There is a huge potential to have a liver transplant facility. Transplant surgeons are here. Believe me, more than 50% of the transplant surgeons working in a different institute, running a different institute, they are from KPK. So you have a class private hospital facility with all the infrastructures and a tertiary care teaching hospital. So all these facilities, they have a huge potential to have a liver transplant facility. But honestly, it's really sad for me that none of the hospital physician or group of physicians from KPK had shown any interest to start a liver transplant program. So if someone is truly interested to start a liver transplant, PKLI will be more than happy to help them in terms of training, in terms of HR, and to start up a liver transplant facility. Even for us, we can do free clinic in your major private and a public hospital facility. Challenges of liver transplantation. Arnold Schwarzenegger, maybe most of you know him. He was born in Austria in a farmer family. He was forced to stay and he was forced to do what we are doing in Austria. But his vision and goal were different. He became the first Mr. Universe at the age of 20. Then he became a Hollywood star, and then he became governor of California. So what he said, I have heard all my life that this is impossible. You can't make it and you are going to fail. But I don't. I don't listen to them and I made it. And I still remember when I joined Shifa as a trainee, so I was among the first trainee of liver transplantation at Shifa. So one day, a consultant, he was sitting with me in the cafeteria and told me, Dr. Hassan, why you are wasting your time? There is no future of liver transplantation in Pakistan. So just go and start your practice. So I went to Dr. Faisal and told the story. So Dr. Faisal, he told me that don't listen to them. Just focus on your work. And believe me, I will change you and you will be a transplant surgeon. And I still remember in the middle of my training, I think Dr. Saleh is sitting here. So the question he was asking me, Dr. Hassan, dalta khoshalai kanai. And the other question, dalta khoshalum nahi kana, dalta ki hospital ki pati kiga. Because the future jide kana aga padi field ki de. So thank you, sir. So the first, public and medical community awareness. Believe me, there is still a lot of negativity regarding liver transplantation, not only in the public side, also in the medical community side. And sorry to say, some of the GI physicians, they are still not in favor of offering a liver transplantation to the patients. So remember, liver transplantation is the permanent solution for end-stage liver disease and HCCs, those who fall in the liver transplant criteria. So there is a lot of work needed to be done on the education, counseling, and awareness side. Infrastructure and equipment. So most of the current facilities, either it's on the private side and the public side, both of them, they have dedicated areas for patients, including ICU, the surgical ICU, and the medical ICU. And they have a diagnostic facility as well. The only thing you need to have a liver-specific instrument, equipments, and the HR. And believe me, the HR, including a nursing staff and a transplant surgeon and physicians, a lot of people are trained on this side. So you can easily hem. Donor challenges, yes, it's a huge challenge. Most of the time, patient come up with their own donor, but sometimes they have unclose family donor who are not willing to donate the liver, and sometimes they have a close donor, and the patient is not accepting him as a donor because of the donor mortality and morbidity. So sometimes the donor and the family, they try to blackmail you, but don't be. The other issue, which is the blood group compatibility, to overcome this blood group compatibility, we have started auxiliary liver transplant. We have started the swab or exchange liver transplant, and there is a need to have a trans-institutional swab transplant. For that, we need to have a donor registry, central donor registry. Yes, most of the time we are rejecting donor due to multiple reasons, and will share you my PKLI data. Donor safety, remember, donor safety is the topmost priority in any living donor liver transplant facility. So this is our data of liver donor rejection. This is our data of 1,000 donors who were rejected due to multiple reasons. If you look in detail, majority of the donor, they were rejected because of this growing problem of MESELT. The other problem due to the donor is rejected is withdrawal of consent. Most of the donor, they come up with the counseling that you are going to donate a small piece of liver and you will have a small incision. And when we counsel them that you are going to donate 70% of the liver and you will have a big incision, so they back out. Fear of death. Donor surgery is a major surgery. And donor mortality for those who are donating a right lobe is 0.5%, and for those who are donating left lobe is 0.25%. So far, out of 890 transplants, we have zero donor mortality. But yes, there is a decent size donor mortality in other centers. And remember, donor death is a death of your program. To overcome all these donor issues, there is a need to have a disease organ donation. And PKLI have worked with the Punjab HOTA, and we have completed almost all the policies and documents, and now it's the time for the government to implement. And there is a lot to be done on the awareness and education and counseling for organ donation. Financial issue, yes, it's one of the biggest issue for those who are from middle or low class families, because it doesn't include only transplant surgery. It includes a pre-transplant workup till the post-transplant, long-term post-transplant follow-up. So the initiative was taken initially by the KPK government, then it was taken by the Punjab government. Now they are offering a liver transplant with the Sehat Sahulat card. This is a team. You need to have this team, including the surgeon, physician, and the supportive staff. And this is the major side which need to be taken care is the post-transplant follow-up. And the liver transplant surgeon and physician, they need to be vigilant, including the coordinator and the management as well, to see all the legal and ethical side of the transplantation. So things do not happen, things are made to be happen. And you don't have too much time, just do it. And this is a paper which was published in 2023 by a PKLI team, liver transplantation, a right or a privilege, sustainable liver transplant financing with an innovative model for the developing world. So this need a good read. So in summary, liver transplant is successfully established in Pakistan. Liver transplant is done almostly from the living donor. A lot of work need to be done on the disease donation side. Funding by the government for majority of the transplant recipient need to be ensured. So this is Amin behind my success. He's my youngest uncle, but for me, he is more than that. Whatever I am today is because of him. Thank you.
Thank you, Dr. Ihsan, for sharing such a wonderful yet exciting transplant journey. Our next talk is by Dr. Professor Hasnain Ali Shah on ACLF. Professor is working as consultant gastroenterologist at the Aga Khan University Hospital, former head of the Department of Gastroenterology. Professor Hasnain Ali Shah.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everybody. It's a pleasure to be here this afternoon and giving a talk. The patience of the KP audience is really commendable. It's been a long day, but still the hall is full till the end. So I will talk about acute and chronic liver failure, which has been on the medical scene for about 25 years now. 1995 was when it was first presented, but people did not believe it was a real entity. But now it is very much established around the globe. And there are about 13 or more definitions in different parts of the world, and still no consensus. And the management, although, is quite clear that it has to be done intensely. So it is believed to be a distinct entity, which is not acute liver failure or not a decompensated chronic liver disease. It is something which has a great potential for reversibility
and has to be managed somewhat differently in that very early decisions, pertinent decisions, and that the treating physician has to understand that there is a very high mortality you treat or don't treat, so one has to act very quickly within the first 24 hours or even 12 hours of the presentation of the patient. So I would take the first definition, which is the easel definition, which states that it is an acute deterioration of pre-existing chronic liver disease, usually related to a precipitating event and associated with increased mortality at 3 months due to multi-system organ failure. It's important that the easel definition encompasses all the 6 major organ systems. So it's very intense evaluation of the failure of different systems as a result of a precipitating event. And this precipitating event or the acute injury can be something which is targeting the liver itself, such like a drug-induced liver injury or a DILI, alcohol, new onset of viral hepatitis, or reactivation of old disease. It could be the Budd-Chiari syndrome, the acute Budd-Chiari, or events which are systemic in nature, surgery, infection, trauma, variceal bleed, which ultimately affect the liver function. The apostle, which so to say is the Asian or the Eastern definition, states that it is an acute liver injury manifesting as jaundice, serum bilirubin of 5 milligram percent or more, and coagulopathy of INR 1.5 or prothrombin activity of at least less than 40%, complicated within 4 weeks by ascites and or encephalopathy in a patient previously diagnosed or undiagnosed with chronic liver disease. So, East versus West is an ongoing controversy that in the East it's mostly infections or sepsis, acute hepatitis or a reactivation of hepatitis, whereas in the West it's mainly alcohol, DILI, or autoimmune liver disease. But by and large, the world over, sepsis is the precipitating event. The pathophysiological mechanisms involved in ACLF involve the intense occurrence of SIRS, systemic inflammatory response syndrome, which is due to and ultimately leads to sepsis and organ dysfunction. And this is on a background of decreased hepatic reserve and altered hemodynamics in the splanchnic, renal, and the peripheral circulation. So, this leads to elevated levels of inflammatory cytokines, that is IL-2, IL-6, interferon gamma, TNF-alpha, which activate the programmed cell death pathway with a decrease of the neutrophil function and immune paresis. So there's initially very severe inflammatory activity followed by immune failure. But this is very well depicted by this diagram, that in the normal patient there is initially an immune response to the inciting agent which goes down below the baseline, and then ultimately in a survivor it comes down. In case of ACLF, there's a heightened response as shown by the green curve, which ultimately settles down, and if the patient makes it, the immune function comes to normal. There is ACLF vanishes and the patient becomes normal. Whereas in the case of ACLF non-survivor, which is the blue curve, which shows that there is a very intense inflammatory response or the immune response which does not come back to the baseline. This table has been taken from the landmark study published in Gastroenterology from the EASL consortium by Moreo, Rajiv, Jalan et al., which gauges 6 key organ systems: liver, the kidney, brain, coagulation, circulation, lungs, and marks are allocated from points are allocated from 0 to 4 considering how much derangement of function there is. And the letterings in bold are the ones where they gauge that this is organ failure, failure of the organs, and the marks are assigned to that. And more the marks, the worse is the function. Next, please. So, as per the points to the marks attained by the patient as far as the uh, organ failure goes, first is the no ACLF situation where there's no organ failure or single non-kidney organ failure, and the serum creatinine is less than 1.5 milligram percent, and there's no HE. 1A when there's single renal failure only. 1B when there's single non-kidney failure, the creatinine is between 1.5 to 1.9 milligram percent, and or HE grade 1 to 2 only. ACLF2 is when there are 2 organ failures, and ACLF3 when there are 3 organ failures. Next one, please. I'd like to present here experience from our own country, from 5 different centers from Pakistan, from different ends of the country, where we analyzed as a cohort based on the EASL criteria the patients who were admitted with decompensated liver disease termed as AD, and we saw how many of them had actually ACLF and what grades and what the outcome was. So it's a complete analysis, first time presented on a large number of patients, almost 900 patients from different parts of Pakistan. Next one, please. And these are the centers and the key persons involved from the Khan University, JPMC, Dow University, Malaria Reading Hospital, Peshawar, and Sheikh Zayed Hospital. We see that the leader is over here in the audience as well. A lot of hard work done. So these are the definitions which were worked on. AD is defined by one or more of the following in a patient with cirrhosis, jaundice, ascites, encephalopathy, GI hemorrhage, sepsis, and is the main cause of hospitalization. Pretty standard definition of AD. AD often develops without significant organ dysfunction, whereas in a subset of patients there could be failure of organs like liver, kidney, brain, lungs, coagulation, and circulation. And the term acute and chronic liver failure, ACLF, is used for patients who fulfill the laid down criteria which I showed a couple of slides ago. There are several different definitions, but no universal consensus on this. So, in our experience, we saw that the ACLF patients, which are about 44%, 393 out of the 892, they were comparatively younger, and they were lean. The BMI was less, otherwise normal. And we see over here that the ACLF patients most often have leukocytosis, PSC, present with variceal bleed, ascites, jaundice, SBP, the HRS, encephalopathy, which is worse in the ACLF as compared to AD. And the most important thing is that the 7-day and the 28-day mortality is worse in ACLF as compared to AD. And that's why I said that one has to act in haste. One can't afford to lose time, or one would lose the patient. May I have the next one, please? We saw that about 60% of patients had hepatitis C. It's quite unique because most of the surrounding areas to our country don't have HCV. And we found that patients who had HCV were older, and they were more often females. Otherwise, next one, please. And we see over here that again that the HCV associated ACLF had more often PSC, presented with variceal bleed, and they had worse encephalopathy. Otherwise, they were much the same. Mortality was the same between C and non-C. Next one, please. And we see that the factors associated on a multivariate analysis with ACLF versus AD showed that age, BMI, variceal bleed, the grade of encephalopathy, and jaundice were independently associated in a positive way with the occurrence of ACLF as opposed to AD. Next one, please. And in case of HCV versus non-HCV patients, the multivariate analysis revealed that age, PSC, and the grade of encephalopathy were again independently associated factors with hepatitis C-related infection. Next one, please. So we conclude on the basis of this that HCV is the most common cause of ACLF in Pakistan, which is unique. There is no significant difference in mortality in HCV and non-HCV related ACLF. In the short term, mortality is significantly increased in ACLF compared to AD patients, implying early recognition and treatment of ACLF patients. Now we move on to the treatment, and I'll try to finish in time because some time was lost when we were trying to adjust the slides, etc. It needs a dedicated ICU and multidisciplinary team management right from the word go. A careful early assessment of liver failure, the extrahepatic organs, infections, sepsis, fluid, and the electrolyte balance within the first 24 hours of assessment have to be done, and the need for liver transplant to be assessed. So it has got to be the transplant team which is involved once the diagnosis of ACLF is made. Has to be ID people, renal physicians, transplant physicians, and intensivists. And then therapy, which is to be used as a bridge therapy to liver transplant, has to be instituted very early, and the judicious use of fluids, electrolytes, antibiotics, vasopressors, and monitoring tools to be done. In cases of treatment of ACLF in an effective manner, nutritional assessment and interventions have to be done very early because these patients are often hypercatabolic and go into a negative nitrogen balance very soon. So different tools which have been employed include the Royal Free Hospital nutritional tool, Nutrition Risk Score 2002, and the Multi-Nutritional Universal Screening Tool, and other scans like the CT scan at the L3 vertebra level to gauge the sarcopenia and the myosteatosis, and on competing risk analysis for liver transplant, age, ARC score, and sarcopenia have been seen to be associated with 90-day mortality. What should be aimed for is that there should be a 30 to 35 kilocalories per kilogram body weight of diet instituted, and where daily protein intake of 1.2 to 1.5 kg body weight should be aimed at. Next one, please. In case of antiviral strategies for ACLF, HBV reactivation, the WHO guidelines for 2024 include the following for treatment: that patients with an EPRI score of 0.5 and the LSM of more than 8, irrespective of DNA levels, the therapy should be instituted early. And when there is a DNA level of more than 2000 and ALT above normal, patients who had sepsis, diabetes, and MEFR, patients on immune suppression and with extrahepatic manifestation of HBD, treat with TF, TDF, and entecavir in standard doses. And if there is an HBV decline by log 2 at 2 weeks, it means there's going to be improvement in the severity scores and survival. Next one, please. Corticosteroids have been shown to improve the short-term survival in patients who got a MELD score of between 25 and 39. However, the incidence of sepsis and the extrahepatic organ failures is high. The cumulative response rate is less than 50% in these patients treated or untreated with corticoids. And the prophylactic antibiotics can be used with which reduce the infections but without any survival benefit. Next one, please. Drug-induced liver injury in the West especially, and the AIH-induced ACLF are very common factors in ACLF. And the steroids are the first line of treatment in AIH, but the data on AIH, ACLF is lacking. Advanced age, a MELD score of more than 27, the presence of encephalopathy, fibrosis grade F3 or more are markers of poor response. And the development of sepsis following the start of therapy is a potential risk and a marker of poor outcome. The primary treatment of DILI ACLF is to withdraw the offending agent, although NAC and steroids have been used in DILI, but data are lacking for both agents from prospective studies. Next one, please. Now we move on in the last 2 or 3 slides into the emerging therapies in the ACLF, which is the anti-inflammatory, the immune modulative, regenerative, and the cell-based therapy. And there's a use for anti-inflammatory agents, immune modulative therapies, the regenerative therapy, liver dialysis, plasmapheresis, and artificial liver support systems. But these things are yet being evaluated and not done the world over. Next one, please. Fecal microbiota transplant is something new and very innovative because the ACLF is associated with intestinal dysbiosis in the context of microbial composition, diversity, and functional metabolism, and that a specific gut microbiota patterns are associated with ACLF, and the gut metabolites interact with each other to produce the symptoms of ACLF. The fecal microbiota transplant has shown benefit in severe alcohol-related ACLF, but the clinical utility of it in the other forms of ACLF remains to be proven. Next one, please. And the other treatment modality is yet being evaluated, that is regenerative and cell-based therapies, the use of GCSF and the GCSF mobilized bone marrow stem cell therapy, and that further studies with GCSF combined with TLR4 inhibitors are underway, and the use of mesenchymal cells, the MSCs, needs further evaluation in controlled studies. Liver dialysis, plasmapheresis, and other artificial liver support systems have a great potential, and TPE is a useful modality in ACLF as a bridge to liver transplant, and the role of MARS and other artificial support systems in ACLF remains not fully understood and needs further studies, which are ongoing the world over. Next one, please. So I'm sorry to have finished about 30 seconds late, but it was a lot of ground to cover. ACLF itself and then the treatments. So I've just run through a summary of what it should be. So thank you very much, Mr. Mon. Thank you, Mr. Chairpersons, who have borne with me for this afternoon. Thank you, Professor Hassan Ali Shah, for the engaging and informative session. Now, for the last, not the least, So for the last session, no, the presentation, I'd like to invite Dr. Mohammad Saleh to share his expertise on post-transplant stricture and how to manage it. Dr. Saleh is working as a consultant gastroenterologist at Shifa International Hospital with special interest in transplant hepatology and intervention. Dr. Saleh.
Thank you, Numan. I'm really indebted to the organizing committee and more so to our brother, elder brother, Professor Sher Rahman, and my brother Kamran and Arshad, and the whole team. I once again congratulate you. Just I'll take 30 seconds extra. Ehsan showed you a picture of Yasin. We did his transplant on 30th April 2012. And I was sharing his picture. I have it in my phone. Recently, he visited me, and Alhamdulillah, now he is a father of 2. So it can change lives. So, however, it's not like that you have changed an engine and you are a tire and it has become a new one. So liver transplant is not something you need to keep them in follow-up, and that's because one, they requires immunosuppressants, almost always lifelong, and they may have certain complications which you need to manage, and they are at risk of other diseases as well. So regarding the post-liver transplant stricture, how to manage, I don't have any disclosures. What are the biliary complications in these patients? They are mainly the biliary strictures, biliary leakages, biomas, bile duct obstruction later on like Cost syndromes or even stones and sludge. Even at times small stents migrated or the graft migrating into the CBD or that. Then sphincter aphrodites dysfunctions and hemophilia. We will restrict ourselves only to anastomotic strictures, and that only in the living donor liver transplant scenario, because exclusively in Pakistan LDLT is available. Now these are the different studies which have quoted various percentages, but somewhere from almost around 5% to 25 or more, like that, these complications may occur. Strictures, Soin has mentioned the last one around 4%, but I think they are more than that, and some of them are having almost 23 or 25%. In our observation, I'll be sharing the Shifa data as well. Incidence is around 15 to 25%. Most common surgical complication, one of the most common surgical complications. I'm not talking about infections and rejection episodes, which is not surgically related. Presentation may be at any time, and the median time to presentation is usually 6 months, and majority of them would occur, almost 90% will present in 1 year. However, I have seen stricture development even after a decade. And recently, one of our colleagues was saying that Nasser was telling me that he had a recent ERCP on someone who underwent liver transplant some 8 years ago. So they may occur anytime. Now, predictors of liver transplant, living donor scenario, in the living donor scenario, for these strictures, what are the predictors? Biliary anatomy, the surgical techniques, size and number of ducts. We are using single duct is available for anastomosis, or 2 or 3 ducts at times even, and 2-in-1 ductoplasty. Hassan mentioned that around 2.4% of their patients' donor rejection was our biliary anatomy. However, I do know that initially they were more like rejecting, and they may have the liberty, but hardly any of them will be these days. Now, if I ask him, probably he may not have rejected a single patient in the last 100. Discrepancy in the recipient and the donor duct size. This is also important. And then if the patient had biliary leaks post-transplant and a redo anastomosis at times when they anastomose and they feel that there is something, then they would redo it. So all these factors are there. And this is also one thing, it's the half liver fitting into the full one. So usually the angle is even at times at 90 degrees, and it's at the cut surface. It's a flushed one like that. So it's a technically challenging because it's not only the ductular anastomosis, anterior, posterior, there are important vital organs like portal vein and hepatic artery. The local experience, both leak and stricture in our published data were around 21%. Mind you, 40% of our patients who had stricture, they had 2-in-1 ductoplasty or had more than one duct. So they were difficult to start with. Now, what are the types of biliary strictures? As we know, we will restrict ourselves to anastomotic, but there are non-anastomotic stricture as well. Anastomotic are but as the name would suggest, single and at anastomotic sites, localized fibrosis due to operative techniques, biliary leak, peribiliary ischemia, relatively more common in 2-in-1 ductoplasty specifically, rather than 2 ducts anastomosis, or when there are more than 1 duct to anastomose. Non-anastomotic, they are usually multiple, diffuse, hilar and intrahepatic due to mainly ischemia and immunologic injury, bile salt related cytotoxic injury. And they are less common in the living donor scenario because the cold ischemia time is shorter. Cold ischemia time means that the liver has been taken out of the liver, they are doing some bench work and preparing it to be transplanted and connected to the vessel. So this time is cold ischemia time. Biliary stricture presentation, clinically usually they may be asymptomatic or only having deranged LFTs, but at times these patients may present with jaundice and itching. And this is a relatively busy slide, but that's how you should proceed. If you get to know that elevated liver enzyme, so first think of liver toxicity. This is important because there are so many drug-drug interactions going on. Then you look at the ultrasound, there steatosis absolutely normal, or there is some biliary dilatation. Usually these patients are a little notorious that bile ducts may not be that dilated, despite that they have got high bilirubin even. Then, of course, vascular injury. If steatosis, you go that way. If biliary obstruction, then the next step will be to confirm it through the MR cholangiography, and then you will go and deal with. If it is normal, then of course you need to look at whether it's recurrence of the disease, hepatitis, de novo hepatitis, rejection, de novo autoimmune hepatitis. So all these things are there. And of course, for the vascular one, you need to do a Doppler and a triphasic dynamic MR or a CT scan and manage accordingly. The management approach is endoscopic retrograde cholangiography. What happens if you are successful? There's another issue, but if you are not successful, then you may have a second attempt by you or somebody else. One, if that fails, then you need to consider PTC or rendezvous technique. Even if that fails, you may go this way. However, now we may have the option of cholangioscopy as well, which could be transpapillary or even transhepatic, provided your center have the expertise as well as availability. If this is successful coagulation, if it's a bile leak, it's okay. It's a different thing. You need to put a stent in to bridge that. If there is a biliary stricture, then the second thing would be whether you can traverse the stricture or you cannot. If you cannot, then of course, this is again, if you can, then of course you need to dilate or do a biliary stenting and all that. But if you cannot, then you need to go to the other one, which is a PTC. Consider cholangioscopy if available to you, transpapillary or otherwise. If that is failed, then it's surgery. And surgery is usually, the chances of referral to surgery is less than 1%. Now, these are all those pictures which one gets when you do a cholangiogram on that. And there are all types, because the reason is they are swan neck and like, I would say swan, goose, anything. And because the problem is, it's not only at this angle, this is a three-dimensional change because there is a cut surface and the liver grows. And when the liver grows, so the growth towards the capsule side and the other side is different. So look at my hand. It rotates this way, it rotates this way, and it rotates this way. So at times it can be disastrous. The angulation even, you may be even seeing bile there, but getting there may be unfortunately technically difficult. And that's how it rotates on all these y, z, and x axes. Now, by type of presentation, if they occur within 3 months, we call them early. We do not dilate them because there could be a chance of dehiscence, or you may disrupt the anastomosis, just stent them. But they do require less sessions. Because reason is you put a stent there, they will heal on it, and it's okay. However, if they present late, then they require more sessions, more stents, dilatation and stenting, and probably more than one, and even at times more than few. But before you attempt at ERCP, anatomy is essential to know. So you should be knowing what's the graft type. Is it a right lobe, a left lobe, a segmental, or what? But in segmental, usually in small children, they will be having a biliary enteric anastomosis, so we don't do ERCPs. Or it's a dual graft. Then what's the anastomotic type? It's a duct-to-duct, single duct, 2 or 3 ducts, 2-in-1 ductoplasty, or is hepatogenostomy? And do you have the expertise to do it in hepatogenostomy, the gadgets and everything available to you? Believe you me, once we were tricked into an ERCP on a 9-year-old young girl, because they were telling us, providing us that she is having a duct-to-duct one. And my senior, Dr. Najmal Hasan, told me, this lady has been sent by someone, please do it, otherwise किसी और शहर में भी मुंह दिखाने के काबिल नहीं रहे. And it was absolutely nothing. मैंने कहा सर फाड़ देंगे, कुछ नहीं लगता. Are you sure the anatomy is like this? She's again called at the same time. Somebody said, yes, it's duct to duct. And then in the evening, we failed, and she said, unfortunately, somebody said, oh no. And later on, then we called then a person who had done it, and he said, I have never done a transplant on a child in Pakistan with a duct to duct. Luckily, we were saved. Then I said, okay, I can't do it. We stop it here. Biliary anatomy, operative notes, most important. So in Chinese patient, we have got a little problem. Otherwise, we do have these notes. Operative cholangiogram, we do ask them to provide the cholangiogram, and of course, MRCP. Biliary anatomy is important, because if you look at this one, this is a bit of a bad projection, but it's from 2018. One of my patients, is he outlining it? But I knew the anatomy. So I was negotiating wire here, even including cholangiogram, there was nothing. And you will see here, it's a whole sector rather. So you will miss that. And it's just a smaller one if you look at here. So you need to know. So I knew it, and I could negotiate the wire with the help of balloon. And then after that, we dilated it and stented it. So you need to know the anatomy is important. Early biliary strictures, if you look at this one, you may see even still the drains present there. And this is a small stricture. Just there. It's an early one within, this means within few days after the transplant. That was the cholangiogram of this patient. And we just quickly place a stent there and job done. Now, usually we say that these ducts are not dilated, but this is one of our patients from 2016. You can see here the drain is still present. And when we were doing the lefties got the range, when we did an ultrasound, they told us that there is some biliary dilatation. So at times can be there. And then we placed 2 stents because it was conducive. Early stricture, easy to traverse, but be careful, because technically difficult patient is usually in supine position. You can't toss them up. The graft, there is some, that is half the liver, so you can't move even the patient. The right side can never be up. So patient, if it's a right lobe graft and vice versa, disruption of anastomosis may occur, a leak may happen, so you may complicate the thing. Left lobe graft, this is one of our patients. She had left lobe, but with duct-to-duct anastomosis, a young child. So this was, the second one is available to me, not the first one. So we had one stented her, and then we dilated that. And then after that, we put 2 stents. One thing, people among you who are doing these ERCPs, somehow the angle is like that the proximal displacement of stents are more common here than the distal one. So I usually would improvise and I will have a lasso. And then it was the final one once it's resolved. The right lobe graft. Now, if you look at here, this is the first one and then the other one. So both of these ducts have got two ducts and things, and you need to dilate them. And at times you may use different balloons to dilate them, and then you will place multiple stent, 2 stent in this one and 1 in this one. The right lobe graft, again another one here, and attempted ERCP, but we could not. We didn't have we are in the process of acquiring the cholangioskope now, but we didn't have that, so we could not cross the stricture. So what next? We asked what are the options to us? Of course, cholangioscopic assisted wire placement, PTC, whether a rendezvous or a PTBD. I'm not that great fan of the rendezvous procedure. I just am okay if you crossed it, put a drain in, and I'll do it after 2 weeks or so. So they tried, couldn't cross, unfortunately. What next? Before you move on to, if you have got a cholangioscopy, it's okay, but before you move on to the surgery, we reattempted after 1 week, and luckily this time we were able to place the tube in. Now, then after 3-4 weeks, I went in again, and I will remove these over the wire myself rather than moving them into the IR suite. So you need to open them up or access them through the wire, and then, of course, we access it, dilate it, and then placed stent. So optimal dilatation and multiple stenting. What that means, if you look at here, this was from that one, the first one, and now we are having its second or third ERCP probably on this patient, and you need to dilate them properly. This one was a little open one. This was still having a little longish and not that open. So we opened it up and we placed this time 1, 2, 3, 4, 5. And those of you who knows, these are all of 10 French size. So you need to dilate them enough, and then you need to place them multiple stents so that it's dilated and to keep them open. Surgical intervention, when both of these fail, and radiological approaches as well fail, and of course cholangioscopy also fails, then you need to do a PTBD initially to drain them externally. Usually hepatogenostomy is the way forward by the surgeon. Sometimes duct-to-duct anastomosis may be possible, and I'll be sharing one patient with you. Professor Kashif Malik sent this patient to me way back in 2019, if you remember. 2018, late 2018, sorry. So it was like that. So we could be able to go into this one, but we know the anatomy. And as the drain was present in the other one, the external drain was present. So I also externally put the dye in while doing ERCP. So this one is separate one, this one is separate one. So what the way forward was to go for surgery. Luckily, we had a very good Chinese surgeon visiting us, and we put this patient for the list, Professor Chu's assistant, Professor Wei Lin, and he had fortunately connected them. And I asked my surgical colleague then that please do not remove this drain for God's sake. And somehow or other, over the weekend, someone removed the drain, so I preemptively went in and did an ERCP before it would go back to the odd one. So that's why the ERCP or this cholangiogram is available to us. Now, that patient did well, and I followed her for 2.5 years or so, but for the last 2.5 years, I have not listened to them. Probably Professor Kashif may be following her. ERCP in a non-anastomotic stricture. Sometimes this is one of our patients who had auxiliary liver transplant, and this is the graft from the auxiliary liver, the normal graft, and this one is the most one. Unfortunately, her own native liver did not grow. So it was in November 2015, to be specific. So far, she is, alhamdulillah, she is a dental surgeon now and living a happy married life now. So these are anastomotic strictures, long, multiple, tortuous, but you need to dilate them, and then you need to place long stricture, at times even 18 centimeter of these stents should be available to you, or you may make these special one. So you need to drain all of these. So in summary, strictures are not uncommon, more frequent and challenging in LDLT. Make sure that you know biliary anatomy and MRCP at hand before attempting it, as one may miss a complete sector. Even at one more word of caution. At times, if I'm not sure, I'll do a post-ERCP simple non-contrast CT scan, and then you know better, because at times the graft is rotated so much that you don't know. You will be saying that it's an anterior sector, it may still be a posterior one. Discussed with the surgeon in IR, discussion with these two people as a must. Rendezvous techniques may be required in subset of patient. About 70 to 90% can be managed endoscopically, sometimes with the even more so with cholangiscopic approach, PTC, and then PTB endoscopic failure. On average, requires 3 to 4 sessions. Avoid dilatation in early one. Effective and graded balloon dilatation and multiple stents are required. Selective sectoral stenting is usually required. This is one of our Apostle single topic conference, inshallah, coming up in December. So you are all invited. And I thank you all for your kind listening.
Thank you, Dr. Saleh, for a clear and practical presentation. And I would like to ask the chairs for a concluding remarks, and then we'll conclude the joint session.
Thank you. I would appreciate all the speakers for their brilliant presentation. I have one or two remarks. One is about hepatitis. We need a frequent screening for the missing ones so we can treat them and have a free hepatitis by 2030. And regarding obesity, I think no drug can help the person unless he moves and have active lifestyle. Thank you.
Thank you, sir.
Thank to our esteemed speaker for their insightful talk on excellent topics, and we thank to our audience for their interest and time and listening our excellent speakers. Thank you.
Assalamu alaikum. Good evening. I am thankful to organizers of this wonderful conference, Professor Dr. Sher Rahman, Dr. Kamran Hassan, and Dr. Arshad Jaldoon, for inviting us and chair this session. This was the largest session of this 41st annual conference. 10 speakers were in this session. So I am grateful to all the audience who are still here and listening the talks. So all the talks were wonderful. We learn a lot from these talks. For the time constraints, we will conclude this session. And thanks again the Pakistan Society of Gastroenterology for inviting us on this wonderful occasion. Thank you very much.
Anything, Dr. Amish?
I think this session was very good, and there was more information shared with our speakers, starting from the pregnancy and its complication and liver disease, hepatitis B, C, apart from this CLD, ICC, and transplant and its complications and how to manage them. We learned a lot from our great speakers. Thank you.
So I conclude the joint session. I sincerely thank you all these team faculty members and the audience for the perseverance for listening to the long session. And in the end, I would like all the chairs and the speakers for a group photo.
Here in this hall, I think.
So let us join for a group photo. Sir, Dr. Saleh. Aye, sir. Ji, sure.
अच्छा, डॉक्टर साद ने एक बात कही एंड आई कुडंट एग्री मोर कि जी प्लीज़ जो लोग रूटीन में नहीं कर रहे हैं, स्पेसिफिकली इफ़ यू डोंट हैव द बैकअप ऑफ IR एंड ऑल दैट एंड द सेम डे, तो प्लीज़ अगर डाई छोड़ के फिर खुदा ना खास्ता रह जाते हैं तो दीज आर ट्रांसप्लांटेड पेशेंट, इम्यूनो कम्प्रोमाइज है, तो प्लीज़ परेशानी बहुत हो सकती। आई एम नॉट सेइंग दैट यू कैन नॉट डू इट, यू मे बी डूइंग इट प्रॉब्ली बेटर देन एवरीवन एल्स, बट आप किस हालात में कर रहे हैं या कौन सी सपोर्ट शामिल है, तो मैंने कहा कि मैं प्लीज़ ये बता दूं, ये मैं बता नहीं सका था। थैंक यू।